both, but always kind of organized in such a way that hopefully I will spend most of the time here. So it's should be all under control, even if I'm joining in. But we'll see how it goes.
Okay.
I no longer need to wake you up.
Oh, no, I already had a shower and breakfast and everything. Yeah.
Very good.
Now we had this joke with Ramesh that sometimes things are so slow here in the morning that at lunchtime we're just having breakfast. But
now how do I go off?
Okay. Hi, Keki. Even if I'm joining in, but we'll see.
Professor Toshio with us from Japan. If you unmute yourself, Toshio, unmute yourself.
Okay. Now, can you hear me?
Yeah.
Yes, we can hear you. Yeah, wonderful.
Nice to meet you. Nice to meet you.
Nice meeting you too.
But then the Zoom will go away from here.
Imad,
yeah.
One technical question. 20 minutes each?
Yes.
Plus 5?
20 minutes, and we leave question, comment toward the end.
Okay.
20 minutes.
Right. And somebody has to time the presentation. Yesterday I was doing, but somebody should do it today. Okay. I think we almost there.
20.
I just give one statement. This webinar is dedicated in honor of Professor Albert Roten, the master and the father of contemporary neuroanatomy and microsurgery. And I think we gave an introduction yesterday. And I think I will welcome all of you. And I thank all the faculty and the members from this committee and the invitee for their prompt response and collaboration. And I give the venue to Professor Vladimir Benish, who is going to start today's session with the other moderator he will introduce. Vladimir?
Thank you very much. Let's hope that today it will be as good as yesterday and as important and interesting. I have two other moderators with me, which is Giovanni Broggi and Eckhard Kasper. So we are three. And if Ek is there, Ek, are you there? Could you check the time or?
Ek will be a little bit late. He sent me a message. He's a little bit.
Okay, so
he's having a shower.
I try to do it myself. And if we should start with the lectures. It's up to me to introduce myself. I'm not going to introduce myself. I shall start with the lecture because time is short. So
you don't need introduction.
Thank you. Thank you.
Formally, I can introduce Vladimir Benish.
Let me share the screen with you. And let me talk about the arachnoid membrane and systems and its importance in especially meningioma surgery. The beginning of the lecture will be the same as the last time when I gave similar lecture. There are two main topics and two main spaces where we operate. It's in vascular, read aneurysms. In this case, we are in subarachnoid space and we cut the arachnoid and we open the systems. Just the opposite is true for meningiomas, which are growing extra-arachnoid, mostly the smaller ones. So we lift the arachnoid and we preserve the membranes. That's the main difference between the two neurosurgical big fields. This is the ophthalmic aneurysm, and you see that all the arachnoid of carotid system is cut away. The aneurysm is dissected free from any arachnoid bands. Here is the optic nerve, which is again liberated, and you are in the space which is completely different from the one we are in when doing meningiomas and other scabs. Going through subarachnoid space, you can go from one end of the vasculature to the other, from ACOM to basilar artery, whatever you name it. This is carotid, this is middle cerebral. All the three can be dissected free, and you see that from the approach. You can clip 5 aneurysms from one M1 to the opposite side, M1 to. Meningiomas are completely different. Here is a tuberculum cell meningioma, and you see that in this case we lift the arachnoid chiasmatic system, and this is after the surgery, and the arachnoid bands are preserved, since these represent the border line which we do not cross unless necessary. This is the video just to show you how I lift the arachnoid. Okay, it's at the bottom of the image, and you see that the arachnoid is lifted, it's not cut through, because it's really the natural border, the natural frontier of the meningioma. And as long as the meningioma has a smooth and shiny surface, it's not the tumor, it is the arachnoid. The normal appearance of meningioma is rough and grayish. We have three kinds of growths, as Yashargil has postulated, and that's important for all surgeries. We have this non-adhesive, which is this region of the large parasagittal tumor. Then it's adherent, which is over here, where the arachnoid is already affected, but not the cortex itself. And then it's adhesive, where definitely the cortex will suffer our maneuvers. And this is especially true for skull-based meningiomas, about which I will be talking mostly, because we are not in the complexities. What's important and is depicted on this image is there are two cribriform plate meningiomas, identical in volume, identical in all respects, apart from first the edema. Edema in this case is unilateral, in this case bilateral. In this case, the anterior cerebral arteries are in the midline, and in this patient, they are shifted to the opposite side of the edema. What does it mean? And it's very easy to comprehend. In this case, the left front lobe is covered by 3 layers of arachnoid. The arachnoid is dragged by the anterior cerebral arteries. In this case, both frontal lobes are covered by one single layer of arachnoid only. That means that it's much more endangered the both front lobes, and in this case, where the left side is protected, you most likely will be able to preserve the first nerve, the smell for the patient, which is the case of this patient. It's by the end of the surgery, the tumor is already resected. This is a little remnant at the origin. And what we see in the background over here, it's the opposite side olfactory nerve, which was preserved along with its function. And you see the bed of the tumor is above the nerve, but still the nerve may be preserved because it's still covered by its arachnoid. The anatomy of arachnoid membrane is not really well covered in the literature. These are the Roton's images, which probably are one of the two best, where you see all the system. They are very well defined and very well described, very exhaustively. Still, what we see as the firm borders, it's not always true. Usually, it's not really that through the outer layer of the arachnoid. That's really the firm border, impenetrable. But the divisions between the respective systems is not that clear and not that clear cut. The only structure within the basal systems is the Lillienquist membrane, which usually serves as a division between the supratentorial and infratentorial. You see it very well here. This is already Krut, who published excellent works on anatomy of systems. It was done with the endoscope, and the images are excellent. And if you take a look on many of them, you need to read the descriptions carefully because it's not that easy to understand, but the descriptions are fine. And just check here that it's really not always the wall. It's like bands and strands. I will show it to you a little later. These are our dissections. These are from Tour. Then thanks to COVID, we had to start our own lab. So here is the carotid system opened, and here is the pontine system where the basilar tree, and you see that the only firm structure here is the Lillienquist membrane, which separates the two compartments. This is what I was talking about. It's, the arachnoid is more like a scaffold or something like which holds nerves and vessels in its place. And you see that those are strands, fibers, trabecus. It's not really the wall. Here, the ambient system, crural system, carotid system. This is the pontine system, and still there are not really well-defined walls between the two. And of course, CSF runs freely in the respective system. This is obviously the third nerve. And actually, what we are talking about is a very tiny space. The diameter of the circle is set 5 millimeters. The tennis ball has set 8 millimeters. From acom to the vertebral junction, it's some 30 millimeters. So we are really talking very, very compressed space with the most difficult anatomy in the human body. And this is just interested how it is with Almeft, this great group 1 and group 2 and 3 meningiomas. And really there is the lack of arachnoid membrane between the distal ring and intracranial space. We are looking from below, don't forget that. And this is exactly the dangerous part of the internal carotid artery in anterior clinoid meningioma. The same is seen here. That there is really a space between the carotid, between the supracondylar space, which is over here underneath, and the carotid rings, which actually can be cut, as seen here, but it's not really practical. So on the anterior and middle part of the carotid, you can get easily beyond the distal ring. This is not as easy in the lateral portion and in the posterior portion. Another example of these dissections and how the arachnoid behaves. This is the fifth nerve, this is the sixth nerve in its cisternal part and in Dorellos canal. And you see that the arachnoid of the cerebropontine system is turning like medially when it passes the fifth nerve. So should, here used to be the petrous bone. So should the tumor start here in the superior petrosal sinus, posterior to the nerve, it pushes the arachnoid in front of itself, and the brainstem, which is over here, is covered again by more arachnoid layers. Unlike in this case, if the tumor starts growing more medially, anterior to the fifth nerve, then there is only one layer of arachnoid, and of course, then the dissection from the brainstem is much, much more difficult. Arachnoid systems are important in planning the approach with advanced knowledge of systems and expected layers. What's very important is the tumor origin definition. It's on T2 images, T1 images is gadoids for radiologists, not for neurosurgeons. For neurosurgeons, it's T2, where you quite frequently see the exact origin of the tumor. Defining in which system we are doing our job, it's throughout the surgery, and what structures are there. And what's important, whenever possible, stay within one system. Don't cross the border to the other system. Don't leave in anterior clinoid meningioma the carotid system. Stay within one system if possible, not always. And respect the barrier. In this case, this is the Lilienquist membrane as seen from posterior. This is the posterior clinoid process, superior cerebral artery, and the third nerve. So this is where we are usually coming from, posterior or anterior, it doesn't really matter. So aneurysm surgery is about the arachnoid. The arachnoid do not tear the arachnoid. It's like in this ophthalmic aneurysm, where the, yes, it will. You see that the arachnoid, the optic nerve is split on the surface of aneurysm. And the border between the nerve and the arachnoid and the aneurysm is nearly invisible. So if you dissect the arachnoid well from the optic nerve, then you get the aneurysm, then you can close it, and you see what was the pressure on the aneurysm. Let's go forward. This is after the surgery, after the clipping, and after the liberating of the optic nerve. And you see the preserved arachnoid on the surface of the optic nerve, well-preserved vasculature, and actually the patient's vision improved the day after surgery, even despite the very badly looking optic nerve at the beginning of surgery. It was completely split. Again, meningioma surgery is again about the arachnoid. Do not cut it unless necessary, just lift it. This is the case I was talking about, the petroclival on Petro's apex meningiomas, posterior to the fifth nerve, may look same as those which arise from clival or posterior clinoid region. But these are much easier because there are much more arachnoid layers, at least two, on the medial and anterior border of the tumor, unlike in this case where there is one arachnoid layer only. So let's go through several cases. Simple CP angle meningioma, you never ever enter the basal cisterns. This is the wall of cerebral pontine cister, which is hooked to the dendis vein, and it's never penetrated, and thus the structures are not endangered. This is the fifth nerve, obviously. This is the other case. This is Petro's bone or superior petrosal sinus meningioma, but the one which starts growing posterior to the fifth nerves. And you see that after resection, you have prepontine cistern along with the superior cerebral artery and cerebral pontine cistern, and all the arachnoid walls are well preserved, undamaged. Even the division between the two cisterns is left untouched. And this is how the surgery should look. This is the more medially located tumor, and you get into the cerebral pontine cistern, even into pontine cistern. This is the sixth nerve, and there are only strands of arachnoid which really is preserved, and the dissection against the brainstem which was much more difficult than in the previous case. Ambient cistern meningioma, and you see that after the surgery we were only in the ambient cistern, nowhere else. This is the wall of the cerebral pontine cistern which is preserved and C-junction meningioma, again the same cerebral medullary cistern at the end of the surgery. This is the 11th nerve, this is the 12th nerve, which was doubled in this case, which is two hypoglossal canals. Never ever seen anything like that. Pablo, you can have some remark on that. And again, the practice is preserved, and the whole surgery was done only within the cerebral medullary cistern. No other cistern was entered. Tuberculum meningioma, the same thing at the end. You see the chiasmatic cistern wall, which is preserved against the brain and against the optic nerve, thus nothing should be harmed. Small anterior clinoid meningioma, which is causing vision deterioration, of course, and at the end, this is the carotid wall of the carotid cistern, wall of the chiasmatic cistern, and only the optic nerve is dissected, free tumor is resected. Another anterior clinoid meningioma with completely engulfed carotid artery. The triangle between the petroclinoid ligaments is full. And this is throughout the surgery. You see that here is the tumor, which is partly resected now underneath the optic nerves, and the wall of the chiasmatic cistern is preserved, and the same in the back. Now we are laterally and behind the tumor, which used to be here, and this is the Lilienquist membrane, which is preserved and never entered. Here you see the precum and anterior choroidal, which are still covered by some arachnoid, but since they were within the tumor, they are nearly dissected. And this is at the end. At the end, I dissect the arachnoid rather frequently just to clean the cistern. So here is optic, carotid, basilar bifurcation, posterior clinoid, anterior, and the third nerve. And you never leave the space of carotid cistern resecting such a tumor. So this is what Imad Kanan is always saying, that arachnoid is a friend, and arachnoid belongs to the patient, which means preserve it, do not cross it, do not cut it unless necessary. Do I have a minute or not? Or am I done with time?
No, you are in time.
I am on time. All right. So let me just go through one of the
Yeah.
Phenop-
4 minutes. 4 minutes more.
It's within a minute. Phenopetroglyval meningioma, and there are several systems which needs to be crossed. There are 4 stages: resecting the CP angle portion, then cutting the tentorium, subtemporal portion of the tumor, and the prepontine and interpeduncular part. So what you start with is the 7th ICA and 5th, which is the cerebropontine angle, the cerebropontine system. Then going deeper, you get 5th and 6th. Again, we are still in the cerebropontine system. Here is the 4th passing across the surgical field. So here we are in the ambient system, and we are going forward to the interpeduncular system. This is the opposite side P2. Here are the remnants of the arachnoid on the opposite side, tractus and pituitary stalk, posterior clinoid. The same on ipsilateral side, posterior clinoid, posterior cerebral artery, the 3rd nerve, and the superior cerebral artery running towards us. This is the basilar artery, and you see again that the Lillian-Quist membrane is border which the tumor very hardly crosses. So despite the fact that we were throughout the surgery in 4 systems, we were really stopped by this arachnoid membrane. This is the whole approach, supracerebral infratentorial, the tentorium, and this is the post-op image. We never enter the cavernous sinus, sorry. I don't think it's reasonable when we have gamma knife or cyber knife, so it's better not to cause diplopia. That's it. Thank you very much for your attention.
Okay, thank you, Vladimir. You are in time. Very good. So we can have the discussion and question at the end. So it's my pleasure to call Thomas Santorius that I saw before, dressed in green. You are there, Thomas? Thomas.
There.
He was there.
He was there. He moved away. Shall we ask?
Move to the, Professor Toshio, perhaps if he is ready to present.
Okay.
Okay.
Okay,
So,
I do.
please, you have 20 minutes.
Okay, 20
The
minutes.
is yours.
Just one statement, Professor Toshio, he is the president of the Albert Rhoton Society or Committee, and he has worked closely with Professor Rhoton. Thank you.
Okay, thank you very much, Imado. I am Toshio Matsushima from Japan, one of the Dr. Rhoton's fellows. Today's title is The Evolution of the Cerebral Medullary Fissure Opening, its effect on post-fossa surgery from the fourth ventricle to the brainstem. I am going to talk about the surgical anatomy of the cerebral medullary fissure and the transcerebral medullary fissure approach, also called Tero-Vero approach, with historical review. I had a cerebral medullary fissure is the only entrance to the fourth ventricle without incision of the neural tissues. The fissure is furthermore separated into 2, the ubrotonsillar and medullotonsillar spaces. The right row figures shows the opening of the cerebral medullary fissure, which is a transcerebral medullary fissure approach. I had the opportunities to study the anatomy of the post-fossa under Professor Rhoton from 1980 to 1982. When I performed the project of the fourth ventricle, I learned the anatomy of the cerebral medullary fissure. The fourth ventricle is a cavity sandwiched with the brainstem and the cerebellum. Then there is 3 cerebral brainstem fissures: the cerebral mesencephalic fissure, cerebral pontine fissure, and cerebral medullary fissure. The cerebromedullary fissure is the biggest of the three fissures. I dissected the fissure and learned the actual anatomy of the cerebromedullary fissure in detail. This slide shows a step-by-step dissection of the suboctal surface. The cerebromedullary fissure is hidden by the suboctal cerebral surface. The left tonsil and the part of the biventral lobule are being removed. Then we can see the cerebromedullary fissure. The floor of the fissure is the roof of the fourth ventricle, which is composed of the inferior medullary velum and the terra choroidea. I'll show you dissection of the cerebromedullary fissure using the cadaveric specimen.
Now we are entering the right cerebellomedullary fissure. The fibrous connective tissue between the tonsil and the terra choroidea is being cut. In the bottom of the fissure, a part of the lateral recess can be seen. The biventral lobule is being cut. After removal of the most inferior portion of the biventral lobule, the right lateral recess and the flotulus appear. The posterior wall of the lateral recess is the thick membrane called rhomboid lip. The anterior wall is the flotulus and the roof is the terra choroidea with the choroid plexus. The 9th and the 10th cranial nerves are situated anteriorly to the lateral recess. Here is the foramen of Urushika. Next, the tonsil is removed. As you can see, the tonsil is attached at only one part. It is connected with the white matter of the cerebellum at the anterolateral portion. Now, the supratonsillar space appears anteriorly to the right tonsil. The semi-translucent membrane is the inferior medullary veil. The tonsil is attached at the anterolateral portion. Now the flora of the right cerebellomedullary fissure is entirely seen. The anterior half of the flora is the inferior medullary veil, and the posterior half is the terra choroidea. The choroid plexus can be seen through the terra choroidea. The terra choroidea laterally extends to form the roof of the lateral recess. The boundary between the inferior medullary veil and the terra choroidea, which we can call terra-velar junction, is easily detached. When the terra choroidea is reflected, the choroid plexus attached to the terra choroidea appears. Let us look at the lateral part of the fissure. This is the most lateral portion of the lateral recess. The foramen of Urushika can be seen, and its flora is made of the rhomboid lip. The 9th and the 10th cranial nerves are situated just anteriorly to the foramen.
To my knowledge, Dr. Yunpeng Huang, neuroradiologist, is the first person who reported the anatomy of the fissure in detail. He published his paper on the veins of the lateral recess in 1967. Around the 1960s, he studied the fissure to reveal the cause of the vein of the lateral recess. In those days, there were neither CT scan nor MRI. The angiography was the only tool for the radiological diagnosis. After returning to Japan in 1982, I started the fourth ventricle surgeries. At the beginning, I utilized the transvermial approach, which was a standard conventional surgical approach in those days. These illustrations show the transvermial approach from the old famous textbook, Kemp's book. The approach required the inferior vermis to be incised, and the vermian splitting syndrome often occurred post-operatively. In 1990, I encountered an unforgettable case of the ependymoma. This case taught me a lot. The tumor occupies the entire fourth ventricle and extended inferiorly to the level of C2. In the first surgery, I utilized a transvermial approach. I believed I could remove the tumor totally. However, the tumor recurred in the left lateral recess 1 year after the first surgery. I operated again and removed the tumor from the left lateral recess. From this case, I learned that I should have observed the lateral margin of the fourth ventricular tumor. That means observation of the lateral recess. After this beta experience, I started to dissect the cerebral medullary fissure sufficiently to remove the fourth ventricular tumor completely without leaving the tumor in the lateral recess. Opening of the fissure was very useful for the fourth ventricular surgery, like the opening of the sylvian fissure in the trans-sylvian approach. This was the beginning of the transcerebral medullary fissure approach. Around the time, we had MRI. I studied the cerebral medullary fissure anatomy on MRI and reported the first paper on the transcerebral medullary fissure approach in 1992. In the paper, I reported the MRI anatomy of the fissure and the representative tumor cases in which the tumor was removed through the transcerebral medullary fissure approach. In the right row figures, you can see the case of a Ependymoma in the pons. The transvermial approach requires the incision of the inferior vermis. The incision of the vermis and the lateral retraction of the dentate nuclei have sometimes been implicated in the so-called cerebral mutism syndrome. After starting the cerebral medullary fissure opening, we did not have any cases in which the vermian splitting syndrome occurred post-operatively. In 1997, Kellogg et al. Reported that the cerebral medullary fissure approach did not cause post-operative vermian splitting syndrome with good surgical result of their 11 cases. In 2000, Musi and Dr. Orton presented a beautiful cadaveric demonstration of the fourth ventricular exposure through the cerebral medullary fissure opening. They called it the Terobero approach. This report made a significant contribution to the spread of this approach to the world. Next year, in 2001, we reported the medial type of the approach with the 3 different opening types: extensive, lateral, and lateral recess type. Based on our surgical experience of the 19 cases, each opening type should be utilized appropriately depending on which part of the fourth ventricle has been exposed. For the past 30 years, I have utilized the opening of the cerebral medullary fissure for various kinds of the region in or around the fourth ventricle and developed the transcerebral medullary fissure approach. The approach has mainly 2 routes, medial and lateral route. Since tumor in the fourth ventricle extend inferiorly and laterally through the cerebral medullary fissure, we can approach the ventricle not only from the medial side, but also from the lateral side. First, I will explain the medial route. The medial route means a transcerebral medullary fissure approach from the midline after midline subocular craniotomy. This approach became popular as Terobera approach after introduction by Dr. Musse and Dr. Orton. I'll expensive the medial route, especially the extensive type. Procedure of the extensive type include first, dissection of the fissures around the tonsil. Second, incision of the terra-choroidea, especially the tinea, from the foramen of Majandi to the foramen of Urushika to open the roof of the lateral recess. The incisional line is indicated by blue and red arrows. Third, retraction of the tonsil in the superolateral direction. Fourth, same procedure on the contralateral side. To perform this approach, the inferior margin of the tonsil should be exposed. Sometimes partial C1 laminectomy is required. I'll show you how to open the fissure using the video. The case is cavernoma in the pons. CT scan shows the hemorrhage in the pons. Wide subocular craniotomy was done. Bilateral tonsil and the left PICA. The right tonsil is being lifted up and the right middle tonsil space is being opened. Now we can see the interior of the fourth ventricle, foramen majandi, and the terra-choroidea. The tinea is being incised from the foramen majandi to the ventricular entrance of the lateral recess. There is a stray medullaris. The lateral recess is opened, and then the interior of the lateral recess is further exposed. Thanks to the opening of the fissure, the floor of the fourth ventricle is widely exposed. Now checking the facial curricula. There was a bulging in the suprafacial triangle. We puncture the bulging and remove the cavernoma. I'll show you the removal of the tumor through the medial route. The case is of ependymoma. Enhanced MRI shows the inferior and left lateral extension of the tumor. A tumor extends inferiorly between the tonsil like the tongue. Under the tumor, the caudal loop of the PICA is found. First, this extraventricular tumor has been resected. The area surrounding the obex, large left vein of the inferior cerebral peduncle is present. The tumor is being dissected from the fourth ventricle floor, the medulla oblongata. The dissection is done very carefully. A yellowish thin tissue is left to the floor. The right tinea is being followed to the ventricular entrance of the right lateral recess. The right lateral recess is occupied with a tumor. The lateral recess has been opened, and the right lateral margin of the tumor was confirmed. The tumor originates from the right lateral wall of the ventricle. When the originating portion is incised, a large ventricular tumor is able to be pulled out. After removal of the tumor, the entire of the floor and dilated cerebral aqueduct are seen. However, the operation is not finished yet. Last, we are checking the left lateral recess. The tumor is still present in the left lateral recess. The tumor in the left lateral recess is being removed. Now the tumor removal is completed. The post-operative MRI revealed total removal of tumor. The patient has been doing well without any neural deficit. Next, the lateral route. The lateral route means the transcerebral medullary fissure approach from the lateral side after the lateral foramen magnum approach. This is a case of choroid plexus papilloma originating from the right lateral recess. The tumor was located in the right cerebromedullary cistern and right cerebromedullary fissure, mainly in the lateral recess. It was removed through the lateral route of transcerebromedullary fissure approach, combined with the transcondylar fossa approach. Through the lateral foramen magnum approach, a mass was exposed in the right cerebromedullary cistern. It compressed the medulla oblongata medially and the tonsil and bimedullary lobule superiorly. Gradual opening of the cerebromedullary fissure revealed that tumor was partially located in the fourth ventricle, and it was of choroid plexus papilloma originating from the choroid plexus in the right lateral recess. After opening the right cerebromedullary fissure, the tumor was subtotally removed. A small amount of the tumor tightly adherent to the ICA was left.
You have 2 minutes.
Okay, soon I'll finish. Dr. Abe is reported the usefulness of the unilateral transcerebral medullary fissure approach for the OA-PICA bypass. Certain patients with aneurysm in the vertebral artery or PICA were treated using OA-PICA bypass after opening the cerebral medullary fissure. We call the approach unilateral transcerebral medullary fissure approach. Now I am using other variation of the transcerebral medullary fissure approach. The illustration shows 4 different regions approached through the transcerebral medullary fissure approach. In conclusion, anatomy of the cerebral medullary fissure was demonstrated, and then how to use opening the fissure for the fourth ventricle surgery, that is the transcerebral medullary fissure approach, was also explained. In the approach, the fourth ventricle and its surrounding area can be widely exposed without any incision of the neural tissue. I wrote on the transcerebral medullary fissure approach and its variation in my textbook on the surgical anatomy and the surgery on the fossa from Springer. Please take a look at the textbook. If you want to know about the transcerebral medullary fissure approach, Dr. Lawton told us the combination of the knowledge of the microsurgical anatomy, use of the operating microscope has improved the technical performance of the many neurological procedures. Thank you very much for your attention. Sorry to a few minutes over.
Thank you for your presentation. You are just in time. Perfect.
Thank you.
I think there will be very more questions to you on this particularly successful approach. I think that Thomas Santorius is there. I saw him. Are you there?
Yes, I am. Apologies, I had some problems that I had to
No, you have
sort out.
This is your time, and you will have 20 minutes. Please.
So I'm sharing, hopefully. Can you see my sharing file?
Yeah, it's all there.
Perfect. Okay, well, it's a real pleasure attending this meeting. When Professor Kanan asked whether who would like to join, I immediately responded because Dr. Roten has been very instrumental in my life and my surgical professional life. So it was really an opportunity that I couldn't miss. And indeed, his motto or he's sort of saying that he repeated quite a lot of time that the purpose of anatomy, or a lot of his work and my work, is to make the work of a neurosurgeon more accurate, gentle, and ultimately safe. And probably everybody in the audience is familiar with Dr. Roton's book, so I recommend reading them. Lots of the resources are made available online, particularly via WFNS, but also other resources. And I'd like to again pay tribute to Dr. Roton and all his fellows who together produced tremendous body of material for our generation, but for generations to come. And Dr. Roton donated many of his slides to the Cambridge Lectures in Neurosurgical Anatomy, and I'll be using many of them in the audience. But I also, particularly because of the topic, lateral ventricles and approaches, I need to mention Ramez, who is sitting in the audience, and it's a great pleasure to have him around, and I've learned a lot from him, and lots of his wisdom I'll be sharing here. And also Professor Guilherme Ribas, who has been a great friend and from whom I've learned a great deal over the years. And it's really coming from him that is really sort of part of my subconsciousness, that lateral ventricles are C-shaped. Sort of, you can see the shape, C-shape, and they're C-shaped because they're rotating around the central core, specifically around the thalamus. And this is indeed a prosection that Dr. Ribas has shown many times. And to understand brain properly, the operating brain properly, we ought to understand the brain as it has developed over phylogenesis, which is really reproduced to an extent in ontogenesis of every individual person. It's really an outpouch of the diencephalon, that the T-encephalon arises, and the foramen of Monro pretty much is the entry into the lateral ventricles that starts as a small pouch around the foramen of Monro, then elanders anteriorly and rotates around the thalamus posteriorly and inferiorly. And so really, this is kind of the semi-end product of the rotation. And again, rotation around the thalamus. So, for example, you can see on this picture or transection of the embryological situation that the structures that initially start superiorly rotate around the thalamus and end up inferiorly in the temple area, but because they are on the thalamus, they will be stuck to thalamus. So, for example, you can see that's the origin. Well, it's the head of choroid, but in the rotation, that's where the choroid started, and you can imagine how it was dragged around the thalamus, which is not here. That's the hole here, or the thalamus dragged around posteriorly, and the body of the choroid is thinner than the head, and the tail of the choroid is very thin, and because it's stuck to thalamus, it is on the sort of lateral wall here, you could say nearly floor, at the frontal horn and body of the thalamus, but it is in the roof on the temporal horn, because everything is inverted. And of course, this is amygdala in the anterior roof of the temporal horn. And here is the actual ventricle. So on the floor of the temporal horn is the hippocampus, and on the roof is amygdala, and the continuation of the amygdala really with the choroid nucleus, either tail of the choroid. And this is important to keep this in mind. Now, the as the ventricle rotates around posterior laterally, the foramen of Monro, you could say, also rotates posterior laterally in a way, because there is a gap between the between the thalamus and the lateral structure, which is the fornix. And again, the fornix starts as a fimbria of the fornices on the surface of the hippocampus, and then forms crown, body, and eventually separates into two columns. So between the thalamus and the fornix, there is no real gap. It is covered by a curtain called tila choroidea, and the tila choroidea has two holes, which is the foramen of Monro superiorly, or the superior choroid point, and the inferior choroid point, through which anterior choroidal artery enters the temporal horn. And we can really open the gap if we need to, or sometimes certain tumors and lesions do. So there can be sort of a seamless transition between, let's say, the ambient cistern and temporal horn, or tectal cistern and temporal horn, atrium, etc. You can see the choroid plexus filling the gap between the fornix and hippocampus on one end, and the thalamus and a choroid at the other end. And it's also important to be clear about some basic principles, and one of them is that the blood supply to the brain comes from PL structures, and pia is really what brings vessels into it. And when pia and ependymoma attach together, they form choroid plexus. And really what the choroid plexus, or the really is a curtain that is made of two layers. On the ventricular side, it's the ependymoma, and on the outside of the brain side, it is the pia. And here we have it again, foramen of Monro, choroid plexus stretched between the fornix, which is on the outside circle, and thalamus, which is the inside circle. And I won't be dwelling about it too much. Just want to highlight that the choroid plexus has a rich blood supply from a number of arteries. They're also kind of called choroidal artery, but we won't be going into details of it. But it's important, particularly when dealing with tumors that derive blood supply from it, because it's not just one artery going into it. It's a bit of like a circle of Willis that is being supplied from a number of branches. You have anterior choroidal, medial posterior choroidal, then you have lateral choroidal, and so on, lots of lateral choroidal arteries, etc. For example, the medial posterior choroidal artery, that of course is in the Medial Tentorium, which is the roof of the third ventricle, and then we'll talk about the fourth ventricles today, but it is relevant to fourth ventricular surgery. Also, what perhaps say on this slide, that the structure that is stretched between corpus callosum and fornix, right, septum pellucidum, there's a brain tissue, a functional brain tissue devoid structure, and it can be penetrated, used without any problems. But what we need to be aware is that it is not always as broad as it is on this picture, because sometimes lots of people, particularly with no hydrocephalus and no major atrophy, the corpus callosum and the fornix can be very close together. This is kind of pretty much an average, a normal person's scan. Again, fornix here going just posterior to the anterior commissure, and that's of course, corpus callosum, and in between is the septum pellucidum. So we really be careful when we do septum pellucidotomy or operate on tumors that arise from the septum pellucidum, because of course fornix in particular is in danger. And Dr. Roten and his school were very systematic about how they went about anatomy, so I'll at least today follow the suit. So the lateral ventricles have body, they have anterior, temporal, and occipital horns, and atrium. The frontal horn has walls, and is a medial wall, which is the septum pellucidum, and somewhat the fornices. Laterally, a lateral wall is a choroid nucleus, and the floor is the rostrum of the corpus callosum, and a roof and anterior wall is genu. This was a little bit of a schematic picture. This is a cadaver, and again we see the septum pellucidum in the middle, then partially the fornix, which then blends into floor, and the floor extends into rostrum. And you can see the choroid nucleus, because we know that this is the thalamus striate sulcus between the thalamus, of course, here, and striatum, which is the part of the striatum called choroid nucleus here. And that's kind of a zoom out version of the same thing. And so we won't be going through it very much. It's just showing the fairly angled position of the columns rather than vertical as we sometimes imagine it is. This is a picture from Dr. Sikla's paper, which kind of is one of the good, nice pictures how to access kind of schematically various parts of the body, and you can see that you can access the frontal horn either frontal transcortical or interhemispheric transcallosal. That these are the two principal approaches, and I won't be going through it, but essentially we have veins, and then we go between the dura and medially, and so on down through the corpus callosum, and we then end up in the ventricle of choice. Now, when talking about the transcallosal approaches, I'd like to sort of highlight the importance of corpus callosum, because we always think, where the callosotomy should be and what's going to happen if we perform callosotomy and so on. This is quite a useful review paper by Dr. Gia from Dr. Ratka's team, and I'll return to it a little bit later on. Essentially, these colors represent commissure fibers that correspond to various functional parts of the brain. So in this paper, they sort of list various problems that can happen, and you'll be familiar particularly with various disconnection syndromes, including SMA syndrome, alien hand syndrome, and the discoordination of ability to listen with left and right eye separately. It's similar to alien hand syndrome and so on. I won't really have time to go through it, but I'd like to refer you to this paper. Now, the most important part of it is that all this information is derived pretty much from epilepsy papers, and as such, it's compounded by lots of dysfunctional brains that, of course, patients with epilepsy will have. So the information on the topic is very rudimentary. This table doesn't mention memory, but memory is an important part of the component, although one always has to question how much the memory might have been impaired by potential damage to fornix, either directly or vascular, and so on. I'd like to again refer to Guillermo Ribas and his picture that he keeps sort of painting to us by his words, but I thought I'll give you a little illustration here. Is that corpus callosum, albeit is narrow in the middle, is like the body of a butterfly. The corpus callosum then continues into the hemispheres, as if you imagine so the butterfly spreading his wings and flapping his wings up and down. So the corpus callosum continues into the hemisphere, but furthermore, it it is really complicated network of various long association fibers, not just commissural fibers. So when we go through any part of the brain, we have to be very much mindful of that. So if we, this is a carcinoma of the choroid, very straightforward approach to it, but particularly in the anterior part of the ventricular system, the frontal horn, it is actually really complicated in that you can have a number of lesions. This one is pilomyxoid astrocytoma, for example. This one, I deliberately don't put it here. You can think in your heads what it could be. This is, before and after. And you can see that the fornix is always fornix is to me the ultimate thing to preserve, and it's sometimes going to be very difficult, particularly when it is not so obvious preoperatively, despite of the fact that you may do DTI tractography and so on. You may not be able to identify where the fornix is. So you have to have lots of strategies how to early identify the fornix and preserve it. Now, I won't be going through the details of it because this is way beyond the scope of the talk. So this was initially thought to be ganglioglioma, but eventually was diagnosed as SIGA using particularly molecular classification. Another case, now this one you can see that is a bit fuzzy, and it has what we call Dr. Unto no sign, means probably not indicated to operate, but nevertheless I operated and actually worked fine, but didn't get great deal. The person improved after the surgery, lived for still lives actually a number of years, but it's got pretty bad diagnosis. I'm deliberately showing to the various things because they come in various forms and shapes, and really the key preservation is fornix. For example, here, very difficult to know where the fornix is, but again, we're very careful and preserved the fornixes, because if we damage the fornix, particularly in a young person, this one is 7-year-old, this one 20-year-old student from our local university, as you can see, with various hydrocephalus, but also memory problems. So I usually go to absolute greatest extent to preserve the fornix. So you can see the two fornices preserved. Central neurocytoma. Anyway, going to body. Now, the definition of body is between the posterior aspect of foramen Monroe to where the fornix joins corpus callosum. So again, it is various lengths in different people. And again, the boundaries of the body are thalamus, caudate, corpus callosum, and septum pellucidum, and of course fornix medially. And the approaches can be interfornicial, and I won't be going through it, but perhaps you use this picture here, for those who kind of starting to operate, and this is without any lesion in it. And you can see how sometimes it's difficult to say where the septum pellucidum starts and where the fornix finishes. Sometimes it's obvious, sometimes it's not. And of course, if we start making a hole in the septum pellucidum or removing a tumor and get carried away, we can damage the fornix, and particularly in a relatively benign lesion in a young person, we can cause a lot of damage. So we have to be really careful and clear in our head what the priorities of each surgery are. So we skip through that, and how we access body. Well, body is a bit tricky, but essentially we can go frontal transcortical or interhemispheric transcallosal, but the consideration in interhemispheric transcallosal are bit more complex because it really depends on the angle at which we need to access the lesion. If we go from anterior, there are usually less veins. If we go so straight directly, it is much more problematic, not only because of the corpus callosum functions as we discussed, but particularly around here, we have various more important left to right commissural fibers. Also, the veins are usually thicker, more constant. Excuse me. And if any significant venous compromise happened around the paracentral lobule area, and the consequences could be very severe, particularly if the venous congestion translated into hemorrhagic venous infarct. So again, this is all Dr. Roton's and his group's
Thomas,
picture. Okay, so I will skip this particular case. Just a word of caution. You know, I've operated lots of metastasis in thalamus, and you could say this is kind of a ventricular sort of issue, like this one, for example. The access to it is one thing, but also the morbidity to consider in tumor like this is of course related to the thalamus itself, but also we must not forget that although we operate on the lateral ventricle, the wall of this case, and this is actually a postoperative picture, there's a bit of blood here, but there's deliberately tumor left here because it was firm and absolutely stuck to both fornix and vessels, as you can see on the T2 picture here, that are in the velum interpositum of the third ventricle. So we were really risking damaging either the internal cerebral vein here directly, but also potentially avulsing internal cerebral vein from vein of Galen, etc. Then of course, you know, this is just to illustrate the various sizes and shapes of the tumor. Again, I gave you a bit of time to think what it might be, and you know there's a central neurocytoma, and it poses completely different issues. So this sort of tumor we need to approach not just from up here, but a little bit more horizontal, because it, as you can see, is
over time.
Over time. Okay. So I will quickly move on to the just very end, and I'd like to not finish without it, is that risks. A risk comes from not knowing what you're doing. It's very plain, very simple. And the whole work of Dr. Roton was to dispel ignorance. And of course, he was a very humble person. And often it is the case that arrogance comes with ignorance, but at the same time, in humbleness comes with great knowledge. And he was certainly a man like this. And it is brilliant that WFNS Anatomical Committee decided to dedicate this section to him, and I was delighted to be able to contribute to it, albeit in a small way. Thank you very much.
Okay, thank you, Thomas. Question will be, as usual, come later. Vladimir, would you like to introduce yourself the next?
Yes, please. Pleasure. I must switch on the other computer with the program.
Okay.
Okay.
It's Fernando Martinez, our friends.
Fernando Martinez, yes. Fernando Martinez in surgical anatomy of anterior cerebral artery. So you are on. You jumped.
Okay.
Go ahead, Fernando, please.
Can you see my screen?
Yes, yes, sir. It's okay. Go ahead,
okay.
Please.
Okay. Thank you very much for the invitation. It's really an honor to me be part of this webinar, because in this same day, I can see presentations of great professors that I read a lot of his work, like Professor Kobayashi, Dolenk, Brogi, and Matsushima. I will speak about the surgical anatomy of anterior cerebral artery, but my lecture will be devoted to residents and young neurosurgeons, because it takes to me a lot of time to understand the three-dimensional anatomy of the cerebral vessels, because we can see it in the same way, the surgical anatomy, the arteriography, and the cadaveric anatomy. So it takes a lot of time to me to understand all of these kinds of anatomy. So my goal is give young neurosurgeons and residents some applied tricks applied to arteriography and surgery. So first of all, the anterior cerebral artery originates from the bifurcation of the internal carotid artery. And the artery have a circular trajectory around the corpus callosum and in relationship with the internal surface of the hemisphere. In this trajectory, we can recognize 5 anatomical parts from A1 to A5. A1 is the part that goes from the origin of the artery to the anterior communicating artery. A2 is the subcallosal part. A3, the precallosal part. A4 and A5, the supracallosal part. A4 is the proximal supracallosal part, and A5, the distal supracallosal part. And in this trajectory, and from all of these parts of the artery, we can recognize these branches that the artery gives. This is taken from the article of Perlmutter and Rotten. It's a very beautiful article. So, in this specimen, lateral view of left hemisphere, we can recognize here the carotid artery, middle cerebral artery, and the anterior cerebral artery. Here, the A1 segment from the bifurcation to the communicating artery, A2, infracallosal or subcallosal part, A3, precallosal part, A4 and A5, supracallosal part of the artery. Let's see every part of the artery. The A1 part gives rise to the medial perforator arteries. We can recognize 1 to 11 arteries. This is taken from the article of Rosner and Rotten. And these arteries goes to the head of the caudate, the internal capsule, specifically the anterior arm, and the GPI, and have some variations that we will see. This is an inferior view of a brain. We can recognize here the anterior interhemispheric fissure, optic nerve, optic chiasm, optic tract, olfactory tract, the uncus of the hippocampus, the anterior part of the uncus, and here we can recognize the anterior perforated substance. The carotid bifurcation is located here, and the anterior cerebral artery from its origins go forward and medially to reach the anterior interhemispheric fissure. If we can see through the brain, the anterior perforated substance is located here in this region in relationship with the caudate, the head of the caudate nucleus, the anterior arm of the internal capsule, and the GPI. So this is the territory of the perforator branches of the anterior cerebral artery. This is a superior view of the skull base with the clinoid process, the optic nerve, the optic chiasm, the internal carotid artery, the bifurcation of the internal carotid artery, middle cerebral artery here, and A1 segment here, communicating artery here, and the relationship of the A1 segment with the optic nerve and the optic chiasm. Another specimen, we retract the optic chiasm, and we can recognize here the lamina terminalis, internal carotid artery, A1 segment, anterior communicating artery, and all of the perforators that go to the anterior perforated substance and the preoptic area and the lamina terminalis area. This is another view with the carotid artery, olfactory tract, optic tract here, A1 segment, the perforator arteries here, and the relationship of A1 segment with the gangliobasal region, head of the caudate nucleus, the ventricle, corpus callosum here, and the anterior arm of the internal capsule here. This is a microscope view of the carotid bifurcation with M1 segment, A1 segment, communicating artery here, optic nerve and optic chiasm, the lamina terminalis region here, and all of the perforators going to the anterior perforated substance and the preoptic area. This is the territory of the perforator branches of A1. And Professor Roton teach us that all of the perforators originate from the superior or posterior surface of the anterior cerebral artery. So we can work safely in the inferior surface or anterior surface of F1 if we need to dissect this area in vascular surgery. So again, carotid artery, anterior cerebral artery, and I want to tell you that it's very difficult to identify A1 segments in arteriography, but in the lateral projection because of the direction of the artery. So we can see here the A1 segment, but it's very difficult to identify. It's very easy to identify A1 segment in the frontal projection. We can see here carotid artery, middle cerebral artery, A1 segment, communicating artery, A2, A3, and A4. And we can recognize here carotid artery, A1, A2, maybe A3, and all of the perforators going to the gangliobasal region. Variations we can find is mainly hypoplastic A1 segment and fenestration. I have no cases of fenestration. I will show you only one case of hypoplastic A1 segment. This is a lateral carotid angiogram. We can identify here ophthalmic artery, posterior cerebral artery, and all of the branches of the middle cerebral artery, but we cannot see here the pericallosal artery, middle cerebral artery, and we cannot identify here the pericallosal artery or the A1 segment. But in the opposite side, carotid artery, A1, and the two pericallosal arteries. In this aneurysm case, I cannot identify A1 segment, but I lost the photograph, sorry. The A2 segment is the subcallosal segment. Give some perforator branches, the recurrent artery of Hefner, and two cortical branches named frontopolar and orbitofrontal arteries. We can see here A1 segment again, the recurrent artery of Hefner. This is also the recurrent artery of Hefner, believe in me. And The A2 segment is here in the anterior interhemispheric fissure. This is the orbitofrontal branch, and this is the frontopolar artery. These arteries are in close relationship with the gyrus rectus, so we need to respect these arteries if we have to perform a gyrus rectus resection. The recurrent artery of Hebner is a very interesting branch because it can have some variations. For example, here we can recognize the artery originating from the pericommunicating area of the anterior cerebral artery. And the trajectory in this case is an L-shaped artery, L-shaped. But in this case, we have a inverted L-shaped artery. The recurrent goes in this direction and turn to the anterior perforate substance in this case. So in this case, the artery have a relationship with the gyrus rectus. I published this in the Uruguayan Journal of Clinical Anatomy in 1999. This is a very old draw in which we can see 4 variations in the recurrent artery. First, the L-shaped artery. Second, the direct artery. Third, the recurrent artery. And fourth, the inverse L-shaped artery. The territory of the branches of A2, we can see here the territory, the basal surface of the frontal lobe, and the internal surface of the frontal lobe, and a part of the preoptic area with the perforator branches. We can identify a lot of variation, but I will speak about 3 variations of the A2 segment: the azygos artery, the third pericarosal artery, and the middle accessory cerebral artery. First of all, the azygos artery. We can identify here the carotid, here the carotid, A1, the recurrent artery, and here only one pericallosal artery. This is the azygos anterior cerebral artery. Here we can identify branches to both hemispheres. And here an arteriographic case: carotid artery, middle cerebral artery, A1 from one side, A1 from the other side, and the azygos artery here, divided in the 2 pericallosal here. Another case that we published in the Argentinian Journal of Clinical Anatomy, A1, azygos artery, and here the bifurcation of the azygos artery. This case was associated with brain vascular malformation. The second variation, the third pericallosal artery, called by Lasortes as the median artery of the corpus callosum. We can identify here A1, pericallosal artery here, the right pericallosal, the left pericallosal, and here the middle artery of the corpus callosum, or third pericallosal artery. And here we can identify an arteriographic case with one pericallosal artery here, one artery here, an aneurysm, and the third pericallosal artery or middle callosum artery by Lasortes. This is the third variation. In this case, the accessory artery of the accessory middle cerebral artery takes its origin from A1, but in general, it takes its origin from the pericommunicating artery zone, or maybe A2, is a branch that takes its origin from the anterior cerebral artery, but its territory is middle cerebral artery territory. In this case, we can identify this branch going to the insula, And this is not a beautiful anatomic specimen, but we can identify here carotid, the optic chiasm, A1 from one side, A1 from the other side, the anterior interhemispheric fissure, the middle cerebral artery here, and this artery going to the insula in front of the middle cerebral artery. This is an accessory middle cerebral artery taking its origin from the A1, A2 transition. The A3 part is the precallosal part and give rise to callosomarginal artery and internal frontal arteries. In this anatomic specimen, we can identify here A2, we can identify here A3, and in this case, we can see from the right side, the callosomarginal artery here, originating from the A3 part, and we can observe here a variation. This is a common trunk between the three internal frontal arteries, anterior, middle, and posterior anterior frontal arteries, with a common trunk with the paracentral and internal parietal artery. But in the majority of cases, these three arteries, the anterior frontal, the internal frontal arteries, take its origin from A3. This is an arteriographic case in which we can see here the origin of the callosomarginal artery from the transition of A2, A3. This is another arteriographic case in which we can identify here ophthalmic artery, posterior cerebral artery, and the anterior cerebral artery in the entire trajectory. And we can see here frontopolar artery and the three internal frontal arteries, anterior internal frontal, middle internal frontal, and posterior internal frontal. And here, a common trunk from the A4 part. We can identify here the paracentral artery and the anterior internal parietal artery.
Professor Martinez, 2 minutes.
2 minutes, okay. 2 minutes, okay. This is the territory of the internal frontal arteries, the internal surface of the hemisphere, but also the lateral part of the superior part, of F1. We can see here, this image is taken from Las Ortes when the internal frontal arteries can have anastomosis with the branches of the middle cerebral artery here. A4 and A5, we have seen the paracentral arteries and the internal parietal arteries. This is a picture taken from this beautiful article of Rotten with all of the branches of the anterior cerebral artery, frontopolar, anterior frontal, middle frontal, and posterior frontal, paracentral arteries here, internal parietal, and the posterior pericallosal artery. Again, an anatomic specimen, and again, an arteriographic specimen with all of the branches of anterior cerebral artery. So the territory of this artery is the frontal lobe mainly, orbital and internal surface, the corpus callosum, and caudate, head of the caudate nucleus, the GPI, the anterior arm of the internal capsules, hypothalamus, and preoptic area. So we can see here, here, and here, the territory of the artery and the branches going to the preoptic area. This is A1, optic nerve, and lamina terminalis. So thank you very much for your attention, and thank you, Imad and Vladimir, for the invitation to this webinar. It's really an honor to me to be here with you. Thank you very much.
Thank you, Professor Martinez. It was okay. Thank you. You were on time, and we are going to Rames Kyrilos. Rames, ready to give your lecture on the AVF? Rames?
Yes.
Please go ahead. Your
I cannot share the screen. You need to exit the screen so that I can share the screen.
No, Fernando, you need to unshare. Close the screen. Professor Martinez.
Yes, I am here. I am closing.
It's still there.
No, I am not sharing my screen.
No, your screen is still on. We still see your screen.
Oh, sorry.
It's still there.
I will disconnect and I will connect again. Sorry.
Okay. Okay, Rames, let's. Now you. Rames, it's
Yes,
clean.
I cannot find.
Down at the bottom, green button, share screen.
Yeah, I know. I cannot. It's disappeared from my.
I think Fernando took it with him when he exited.
He probably disappeared. Yes, stolen your share screen.
Unless
Probably wants to talk again.
Shall I swap the talk or? What?
Yeah, no. They said that recording starts, but they have nothing to record yet.
I think try now, Rames. You are the co-host now. It should be possible.
Well, I cannot.
Rames, you are the co-host now. Please try again.
Yeah, Zoom is perfect unless this sort of things happen. I've been there myself in the situation where things are not as they should be.
Unless I go the next talk and I'll go out and come back.
Vladimir,
Okay.
Vladimir, if you don't mind, let's go for the next.
Igor, would you be ready to give a lecture? Igor?
Yes.
So please go ahead, and we shall have Rames following you.
Let me try to share.
Igor Maldonado with relevant correlations between vascular and intrinsic cerebral anatomy. Igor, please.
Yeah, I'm trying to share. Please tell me what you see.
Your screen.
Okay.
It's okay. Go ahead, Igor.
Perfect. Oh, I cannot advance. Yes. Okay. So good afternoon, everybody. I cannot say enough how it is a pleasure to participate in these seminars with you. You know it. In addition to be a very great opportunity with high-level lectures, it's always great to see you. So the subject of this presentation is on correlations between vascular anatomy and intrinsic brain anatomy. I selected for today the anatomical accidents that I consider most important and useful for the neurosurgeon, since we have only 20 minutes. It's clear that the main application of this knowledge is interpretation of imaging tests for surgical planning, especially cerebral angiography. In fact, it's an examination that allows the study of a cerebral vasculature with high level of detail, even tiny vessels. That's why it's still gold standard for vascular morphology. But this examination will not give us any direct image of the brain parenchyma. But it does give us a lot of indirect information. And this kind of study of anatomical relationships is most commonly performed in relation to skull-based structures, bony accidents, foramen, cranial nerves. That's true that usually we do not do this kind of of study for the cerebral parenchymal anatomy, at least not that often. So I'd like to focus on this time using angiographic images. And I like this photo from Professor Roton a lot, because it looks like he's giving the brain to us. And metaphorically, that's what he did. So the dissections are used to do the correlation with angiography, or from Professor Roton and his fellows. So let's start with frontal projection angiography. So a classification from the ICA. So the Fissure classification of anterior segments let us divide the MCA in several segments. So M1 is what we call the sphenoidal segment. M2 is insular, M3 opercular, M4 cortical, and then we have the terminal branches. So the DSA image gives us a basic orientation of the arrangement of the cerebral hemisphere, which is well known. The horizontal segment courses along the base of the cerebral hemisphere, ventral aspect, penetrates the sylvian valley, and then it changes direction. In this so-called false form fold, it's a more a French term, old one from anatomists, and then it bifurcates. The change of direction corresponds to the limbing of the insula, the structure around which the artery curves. It's usually said that it corresponds with the bifurcation of the two branches, frontal and temporal, and superior and inferior. However, there is not a rule at all. Several types of variation have been described as early or late bifurcation, frontal or temporal, early branches. Well, we still can study the relationship between the artery and the lumen because it is always marked by the change in the direction of the artery and not the presence of bifurcation. So we must pay attention to the fact that M1 pay attention to the fact that the M1 segment corresponds to the horizontal part of the artery and not to the part which is proximal to the bifurcation. So in Fissure's original classification, even in the presence of an early bifurcation, the entire horizontal part should be called M1 and not just the trunk of the artery. So if we respect the classification and we name it correctly, the transition M1 to M2 will always be the insular lumen. So along the M1 segment and then in this superior aspect, we see the emergence of the lateral lenticular striate arteries. The penetration zone is the anterior perforated substance. It was mentioned by Fernando. This means that they penetrate behind the olfactory stria. So it follows the direction. I don't know if you see my arrow. Yes, it follows the direction of the olfactory tract. So if I continue posteriorly, I will navigate directly to then. I will pass above the carotid bifurcation, and so they group together. And the most lateral ones, they have to bend to reach this space. And classically, you have this shape of lenticular striate arteries with this S form in the right side and inverted S form in the left side. So then they are distributed, and what we're going to have is this arrangement of the basal ganglia. So we have the putamen more laterally, and the globus pallidus, lateral and medial globus pallidus, but also other smaller elements. And above, we'll have around the lenticular nucleus, we'll have the internal capsula, and also the head of the caudate. And actually, these structures, they are being fed by a long recurrent perforator that is coming from the ACA, actually. Most frequently from the proximal post-communicating segment or distal pre-communicating segment, which is the recurrent artery of Heubner. So this artery, classically, we say that it irrigates the head of the caudate, but also the anterior limb of the internal capsula. What is interesting is that despite being originated from the ACA, this artery penetrates the brain in the lateral lenticular striate group. So it's very, very long one. Another reason why lenticular straight arteries are grouped together in the anterior perforated space, perforated substance, is that they are physically influenced by structures around, such as the optic nerve anteriorly, the chiasma, the optic tract medially and posteriorly. And then, of course, all those structures, they receive perforators. But when you get posterior to this, what we're going to find is all the tiny branches that are coming from the anterior choroidal artery, which is irrigating the optic tract and the posterior limb of the internal capsula. And then also some tiny branches, tiny perforators of the posterior communicating artery. So if we follow the MCA on its course of the transition to M2, there is a lot of important information that appears. So despite the presence of the insular gyri there, insular sulci, sorry, they are relatively shallow compared to what we usually see in the cerebral cortex or in other parts of the hemisphere. So you know, the insula, we can compare the insula with a pyramid with in which the base is medial and the apex is turned anterior and inferiorly. So in this way, when you have this kind of projection, you can have the feeling, we often have the feeling that the distal M2 segments, they are actually diving, they are deeper sometimes than the middle portion of the M2. And that's true. It is like this because it's penetrating the circular sulcus of the insula, as you see here in this MRI. And so it's an important correlation, important landmark. And in lateral projection, what you see here is exactly the same thing, but in another perspective. So the deflection of the MCA branches draw a space, the so-called Sylvian triangle, and the sides of the triangle correspond to the superior, anterior, and inferior, or posterior inferior, as limiting sulcus of the insula. So thanks to those deflections, very narrow deflections, we can locate the posterior Sylvian point, which is the deflection of the last posterior branch, and it's covered by the parietal operculum. It means that when I look at this posterior-most deflection, I'm hidden by the supramarginal gyrus, and also it coincides with the medial and posterior extremity of the most posterior of the transverse temporal gyri. So this is for the posterior Sylvian point. But what about the anterior Sylvian point? That's true that we talk also a lot about the anterior Sylvian point. Actually, we'll find it along the anterior border of the Sylvian triangle. This is where the frontal and temporal operculum are a little bit more distant from each other, form a kind of a lake of CSF, which is covered with arachnoid. On the frontal lobe, what you see is that the triangular portion of the inferior frontal gyrus is retracted in relation to the opercular and orbital portions, so it leaves more space there. And so we'll not have any specific vascular structure for the anterior Sylvian point as we have for the posterior Sylvian point in lateral view. But this is also the place where the insular lobe come closest to the surface of the cerebral convexity, and through which we can often see the apex when you look through the anterior Sylvian point. So the apex is the apex of the pyramid, actually. So in other words, this is the most lateral portion of the insula. And in frontal projection, what you see is that the Sylvian branches move laterally due to the presence of the anterior lobe of the insula. Since the apex is not exactly crossed by any branch, you don't have the exact position of the apex in angiography, but you have the approximate delineation of the anterior lobe of the insula. More distally, after the deflection, the M3 branches will draw for us the frontal and temporal operculum. for a branch of the superior division, as in this example, it's natural that it goes down and then up again as it crosses the lateral sulcus to re-emerge in the cerebral convexity. So what you see is that the branches of the MCA, they make two deflections, one very narrow of 180 degrees, very close to the level of the superior limiting sulcus of the insula, as you saw in the previous slide. And then you have a much more open one as it surrounds the corresponding operculum. So the measurement between the deepest and the most superficial deflection will give you an idea of the maximum depth of the Sylvan Valley, which will be, of course, in the retroinsular space. It was 3.2 centimeters in this case. So this is the most accepted systematization for the vascular branching tree for the MCA. It may be very superimposed on the branching tray of the ACA, depending on how is the ICOM of the patient, but it was not the case here. There are some important elements that are recognizable. Of course, I'm not going to detail everything, but one important one is the angular artery. So it follows the general direction of the lateral sulcus. It crosses the supramarginal gyrus and then reaches the angular gyrus. It's usually a large branch. Is important anatomical reference mainly for functional areas. Is very important. Since it corresponds to the supramarginal gyrus, you have important higher functions that are around. The supramarginal gyrus is considered as a relay in language circuits in the left hemisphere related to visuospatial integration mechanisms in the right hemisphere for right-handed people. And then all the branches that are anterior or inferior to it, the most adjacent one, 3 or 4 branches in frontal direction and in temporal directions will be feeding very eloquent cortical areas. So the parietal, the central and precentral branches, they will be related to the functions you have in those corresponding areas. So somatosensory cortex, primary motor cortex, and finally the precentral cortex and the Broca's area. Although this branching is quite variable. So the Broca's area corresponds to the opercular portion and posterior half of the triangular portion, approximately just above the anterior Sylvian point. We discussed it 1 minute ago. And the 3 adjacent temporal branches, they irrigate the rest of the inferior parietal lobule and then the vernix territory and more anterior temporal areas. For the more anterior ones, as we move away from the vernicas area, we'll have of course, it's variable from individual to another, but we'll have less and less risk of be dealing with a vernicus area, but we have important deep structures here, mainly in the white matter, such as the optic radiations around the temporal horn. So understanding this distribution allows us to understand vascular syndromes in view of the disposition of the homunculus, of the somatotopy, and of course, as the somatotopy of the lower limb is located in the medial aspect of the hemisphere, a truncal infarction of middle cerebral artery usually courses with a disproportionate hemiparesis with brachial predominance. So this hemiparesis is called complete because the face is evolved. However, as a rule, the face is affected in a very heterogeneous way, with the lower portion being much more affected than the upper one. The explanation usually given is that the upper face has bilateral cortical representation. This is evidently not the case for lesions of the nerve nucleus of the nerve itself. So we can still discuss vascular syndrome as a function of the locations of the different areas of the branches and the divisions, superior and inferior divisions of the MCA. But of course, this is does not represent completely all the situations we may have, the variations and the inter-individual variations in the distribution of functional areas, of the importance of leptomeningeal anastomosis, for example, as you can see in this scheme. So let's go to the medial aspect. Let's take a look at the ICA. So same classification, fissure segments. It was very well explained by Professor Martinez. We distinguish bifurcation between pericallosal and callosal marginal, which position is also variable. The emergency of the callosal marginal artery is also variable. It can be in the supracallosal segment, just in front of the genu, or even more rarely inferior to it. The point I would like to stress here, comparing the parenchyma anatomy related to this bifurcation, is the fact that the pericallosal artery will course along or very near the sulcus of the corpus callosum, while the callosal marginal artery will reach the cingulate sulcus. So they advance a few centimeters in parallel, and then the pericallosal artery may or may not have a posterior small branch that will be anastomosed with the territory of the PCA.
Minutes.
So,
Igor.
yeah, I see 2 minutes. Yeah, thanks.
Okay.
Even though there are some variations there, we always have this marginal branch of the cingulate sulcus, and there is always a branch inside here. They may not be the largest one, but it's always present. With some patients, we can distinguish them. And what these branches will do for us is to show where the posterior limits of the paracentral lobule is. So if I find the marginal branch of the cingulate sulcus, I find the paracentral lobule. So I have all the somatotopy of the lower limb. I know that here is the precuneus. If I correlate this with the anatomy of the posterior cerebral artery, I also have my cuneus and my lingula. I just need to understand which branch is going inside the parieto-occipital fissure, with which branch is going inside the calpurnian fissure. So I can know better where things are. If I have the cuneus and lingula, I know where the primary visual cortex is with all the somatotopy. We don't have time for all the venous anatomy, but I would like just to mention this very classical one, I was obliged, which is the Vandals Angle. So we talked a lot about the cortical anatomy, but there's a deeper one which very, very useful. So I'll go back to the other slide. So I have the ICA around the corpus callosum. So I have a very good idea of the location of the roof of the lateral ventricle. If I find the venous angle, the curve in which the confluence of the thalamus striate and the anterior septal veins, or get inside the velum interpositum to form the internal cerebral vein. I have the roof of the
Igor.
I need just 10 seconds. And then this is, I know better where things are. So that's all for today. It would be crazy to show more than this because it's endless. We have all the venous anatomy and posterior fossa and everything, but just a kind of sensibilization. I hope it was useful for you. Thank you very much.
Thank you very much, Igor. That was nice. Both lectures were excellent, since for our young residents, angiography is nearly a dirty word, and they are good when they recognize the internal carotid artery. Great. So let's get back to Ramesh. Ramesh, are you ready? Ramesh, unmute yourself. Ramesh, unmute yourself. Another button. Your presentation is okay, but you are muted. Ramesh, okay. Yeah. Go ahead, please.
Presentation more difficult than neurosurgery.
Okay, thank you. I'll just present today's surgical anatomy for intracranial dural AV fistulas, arteriovenous fistulas. It's a specific talk on surgery, not the whole fistulas. As my brother Tom Santarius said, we thank Professor Broughton especially for his donations to our Cambridge lectures. And the whole idea for dural fistula just to understand the pathophysiology and relevant anatomy to allow the cases that require surgery. Dural fistulas are just an AV shunt within the dural leaves and may involve near the sinuses, but they involve maybe the cortical veins, and they are less common than AVMs, but more important, they have a completely different pathophysiology. And the aggressive ones are the ones that present with hemorrhage or venous hypertension is related to the cortical venous reflux. So the one really we intervene with, either endovascular or surgical, are the one with severe symptoms due to reflux, the ones that presented with hemorrhage because recurrence is high, or have risk factors that increases the risk of hemorrhage. But the majority are either benign symptoms or just tinnitus or incidental, and the majority involve the transverse sigmoid sinus and cavernous sinus, and they are either not treated at all or have endovascular. But we have a group of them in other locations that may not be amenable for endovascular, and we may intervene surgically. And mainly these are the groups that, these 4 groups that are really treated surgically. There is a bit more, but if they can be treated endovascular, that's fine, but they always have difficulty. So you have the anterior ethmoidal fossa, the middle fossa, and then the tentorial petrosal group and the group around the foramen magnum. And what we need to do is just to disconnect the cortical venous reflux to reverse the venous hypertension. This is all the pathology driven. So what I will go through is the anatomy of these 4 groups. And the whole skill is how to use anatomy to localize when you look at the angiogram, or to localize where is the site of the fistula, where is the cortical venous reflux, and then we target it with all our approaches. So the whole idea is to know the vascular anatomy. So really there is 2 components, but contrary to AVMs, or the dural arterial anatomy is very important, and it's something not easily appreciated. And that's why I chose this talk, but however has no intraoperative implications. In fact, you do all the surgery, you don't see a single artery in most cases. So they don't have, not like AVMs. The venous drainage is what we are target, and we have to make sure that we target the correct cortical venous reflux, and not to damage other veins, and to target it at the site as close to the dural as it emerges from the dura as possible, and to choose a good approach that avoid morbidity. So I will go through these groups one by one, some more than the others. This is just a summary of what I'll go through, which veins that are more commonly we disconnect. And just to touch on the meningeal arterial anatomy, this is, if you know it, it's mainly for the radiologist to localize your site of the fistula. So you can see here, this is only a fraction of the cases I operated for AVMs. So they are not as common. But you make a great deal if you make the operation very simple, because the results are very satisfactory when you choose them. So if we start with the first group, which is in the anterior fossa, usually they are more involving, of course, cortical venous reflux. The endovascular find difficulty to get them, and the blood supply of related to the dura, which involves, branches of the ophthalmic artery, which is the anterior ethmoidal artery that comes from the orbit through the roof of the nose, and then enter again adjacent to the crista galli and the falx. So this is an important one. The posterior ethmoidal can be, it is more horizontal, and it's near the optic nerve, but most of the fistulas are involving the anterior ethmoidal artery, which is supplying the dura around the falx. Now, the middle meningeal artery supply a lot of the anterior fossa, but very rarely involved with dural arteriovenous fistulas that require surgery. And the veins that we disconnect is near the crista galli. They present with hemorrhage as such, medial. And if you can see here in an angiogram, this is ophthalmic artery. And you can see this is the site of the fistula. This is the cortical venous reflux with some varix in it. And this Usually when you see it, you would know it is adjacent to the crista galli. They are fixed in location. So this is another example, not the angiogram. So if we see, we approach them with the bifrontal, you can do a unilateral craniotomy, but in some cases, they have contribution from the other sides that involve other cortical veins. And you go interhemispheric, just above the frontal sinus, you divide the sagittal sinus. And this is, as you are orientated, anterior, this is the right side. And you can see the large dilated arterialized veins. You follow them interhemispheric around the crista galli. This is another view, oblique a little bit. And you can see here is anterior. And you go down interhemispheric until you find the site of the fistula. You have to be very careful where it is. You see this is some arteries in the dura, it doesn't matter, but this is the vein that we are going to disconnect. You shrink it with a bipolar, you can put a clip on it and cut it, as you can see here, as it shrinks, and divide it flush with the dura of the falx, because eventually it's giving all the venous hypertension behind, and you disconnect it. And the operation is quite simple. And you look immediately, there is normalization of the arterialized veins, they become blue again. The other group we operate on rarely, less rarely, is in the middle fossa and ethmoidal part. So the middle fossa, this is the dural arterial supply that mostly coming to the lateral part of the anterior fossa from the middle meningeal artery, as you can imagine. We all know, but more medially from a petrosal branch, you can get an accessory middle meningeal artery, but also the ascending pharyngeal arteries through the foramen lacerum around the carotid go more medially in the anterior fossa and give part of the arterial blood supply. Now, more medially in the anterior fossa, and if you were present yesterday, Pablo mentioned some of these arteries that you may not be familiar with that supply the dura and are involved in some meningiomas medial. And any of these, especially the medial group, can get fistulization to the bridging vein around the sphenoparietal sinus, that means around the lesser wing of the sphenoid. They present again with hemorrhage, and usually you approach them transsylvian, you can find the veins and disconnect them. I won't show you much because you are all familiar with these transsylvian approaches. The other group is the tentorial group, because again, the endovascular surgeon, endovascular approaches is difficult to obliterate them in one go. And this is the dural supply of the tentorium. So you get from the meningohypophyseal trunk, from the cavernous carotid, you know, the artery of Bernasconi and Casenari that supplies the tentorial branch and supplies the tentorium. You are all familiar with it. But the middle meningeal artery, the posterior division, again gives supply to the tentorium, and so is the occipital artery, giving a tentorial branch. And this is a very unusual, I would show you an example, meningeal branch from the posterior cerebral artery. And the tentorial groups are either supratentorial or infratentorial, and it's just the bridging vein coming from the tentorium, as you would imagine. They may be adjacent to the transverse sinus. So this is an example of a case with the hemorrhage that we thought it was a small AVM, but the radiologist I wasn't aware of said this may not be an AVM from the posterior cerebral. It could be a dural fistula, and this is a rare artery of Davidoff and Schnetter that gives supply to the part of the tentorium adjacent to the falx and can give a dural fistula. It's very important to know which is which, because treating surgically an AVM is completely different than an AV fistula, where you only target the vein early, while an AVM, it will be a disaster. So we did a selective angiogram. Unfortunately, it was just an AVM. But the approaches is very simple. You know, you can go subtemporal above the tentorium to disconnect the site of the arterialized vein, or supracerebellar to disconnect the group. Now, this is the more common group that we operate on, is the petrosal. It's still a tentorial, but it's the medial tentorium, where as if you are doing microvascular decompression. So again, the blood supply of this lateral part, petrosal part of the tentorium. This is the junction of the petrous bone with the tentorium. It's coming from the tentorial branch, the petrosal branch of the middle meningeal and occipital artery, the same, more or less, and you get some contribution from the ICA. But what's mainly arterialized is the vein of Dandy. And the vein of Dandy, we had a lot of discussion for those of you present yesterday, and it's a very important vein, not because it drains the cerebellum and fissures and fourth ventricle, because it has connection with very important veins. The most prominent of is the transverse pontine vein and other veins around the brainstem. So you can get venous hypertension that goes to the brainstem. That's why when you sacrifice them, and if you are unlucky, then you can have a brainstem venous ischemia. The venous plexus around the brainstem is longitudinal and transverse, and may go to other routes. That's why you can get away with it. But when you have venous hypertension, these are the parts that can be affected. And they can drain into one or multiple branches. So when you target for a dural fistula, you only target the arterialized branch. So this is an example how we do. This is an angiogram. You can see here, this is a cavernous carotid with tentorial arteries, the artery of going to the petrous area. And this is the fistulation going into the venous with cortical venous reflux, and there is a varix in the mesencephalic area. But also on the external carotid, you can see contribution from the petrosal branch of the occipital artery and middle meningeal artery. So knowing the vascular anatomy, just looking at that, you know where's the site of the fistula. So this is and then you go and do it. So this is the orientation of suboccipital retrosigmoid craniotomy, transverse sigmoid sinus. Then we open, this is the tentorium, as if you are doing a microvascular decompression. And this is a complex fistula, but when we dissect, this is the petrous bone. The tentorium is up here. So we are supracerebellar, just to orientate you. Then we dissect the arachnoid, and we find the 7th and 8th nerve. This is the subarcuate artery from the ICA, so it can contribute a little bit to that fistula, but this is the main fistula. And you can see the two branches, but they are connected. So we have to disconnect all this. It is quite large varix. So this is as complex as it can be. Usually they are very simple to find. You shrink it until you can get some clips. Make sure don't put it the whole way, because you have the 4th nerve and superior cerebellar artery in the back, and on the other side, the 5th nerve. And then you adjust the clip to be free of everything, flush, and then move it flush to the tentorium and divide it. And it's a very simple operation once you do it, and this is the result. Now, around the foramen magnum, it is more complex because the venous anatomy is more complex. Now, when we say around the foramen magnum, I mean the region, including the jugular foramen and the hypoglossal canal. And the supply around the meningeal supply, the V3 gives the posterior meningeal branch. This is from the back, as you can see, foramen magnum, the C1. And this is supply the dura here. The occipital artery gives a mastoid branch, which supplies the dura around that area. And then the ascending pharyngeal branch, they give, and the occipital artery give branches that goes to the hypoglossal canal and jugular canal. Now, the radiologist, it's very important to know, which will tell you which branch is responsible to the fistula, because you will more likely find the arterialized vein adjacent to either the jugular foramen or the hypoglossal canal, which help you to target it. But make sure that it's not absolutely true, because the arterial supply not supply a small part of the dura, it goes a little bit around. Now, this is what is important. The marginal sinus is the sinus around the foramen magnum, and this is where the bridging vein goes to, that you can find them. Or you have something more complex, which is the anterior condyle venous confluence around the, I would show you in details, which has multiple bridging veins. So if we look into here, this is the medulla from the back, cerebellum. And you can see here the condyle, we remove the vertebral venous plexus, and at the mouth of the hypoglossal canal, there is this venous plexus with the marginal sinus here, and you can see a condylar vein, a vein going to the jugular foramen. This is the 9 and 10 and the 11. So all these veins can be arterialized, and they are giving backflow if you have a fistula involving the anterior condylar plexus, with all this arterialized, giving either venous hypertension to the cerebellum, medulla, or even the spinal cord. Now, the simple one, which are just going like this one, this is a simple foramen magnum dural fistula, where the cortical venous reflux is one of the bridging vein around the marginal sinus. The marginal sinus, as I said, around the foramen magnum. And all you find, you do a small suboccipital craniectomy, and you find the arterialized vein inside, put a clip, and you target it. Now, in some cases, like in this case, it will be just around the jugular foramen. So here we have the jugular foramen with a big varix. This is the top, the feet is down here, this is the cervical spine, the cerebellum, and this is the medulla. And when we target it, all you need is find the fistula and flush with the dura. And all it needs is a single clip, and the operation is done. Despite having all this complex, we have disconnected the venous hypertension from that area. Now, this is one of the more complex that is around the foramen magnum that is bilateral. So if you go on the left side first, this is cranial, this is caudal, that means the head is here, the feet is down. This is your spinal cord, medulla. So we are going like a suboccipital craniotomy. This is the midline here. We find the vertebral artery, and you can see all these arterialized veins. So this is the hypoglossal canal. You can see a arterialized vein coming here in the hypoglossal canal, and you can see the arterialized vein on the cervical cord. Type 5 fistula, that means they have cervical myelopathy. Then if we go even further on both sides of the vertebral artery, this is below the vertebral artery, we see more arterialized veins. This is in the first denticulate ligament, which we divide, and you can see all this tangle. But what we need is to disconnect it from its dural origin. After dissection, we find the main one. So this is the vertebral artery here, and you can see this. You could be mistaken for a vertebral artery. This is an arterialized bridging vein, and you put a clip as such, and this on itself plus a small other branch has reversed the venous hypertension of the cord. You remove the temporary clip as such, and then put a permanent one. And then we do the ICG. This is pre and post, and the fistula is gone from that side. Now, this is the same patient. We move on the opposite side. This is the midline, the top, the bottom, and we have a more complex fistula here. Now, this fistula is around the vertebral artery. And if you look on the top, this is the hypoglossal canal as well. This is the spinal accessory. And we can see many arterialized branches coming from the dura from here. Can you see correlated with
2 minutes, Ramez?
That's correct. And this is one of the branches. As you can see here, we disconnect it. And then you have to look further down. So we went down and we find more and more branches. Because this one is coming from the anterior condylar venous, as I told you, confluence of veins that has multiple branches. So not a single branch. And this required, as you can see, multiple clips. And this is the vertebral artery at the end. This is to show you how many clips there are, including the hypoglossal canal. And then finally, with the ICG, the fistula is gone. This was done. I just emphasize, don't do a far lateral approach, a midline, because you want to look lateral to the jugular foramen hypoglossal canal. The mistake is to do a far lateral approach because you want to see the entrance of the veins from this point of view in this trajectory to divide them flush with the dura. So the good outcome is really to make the operation simple if you understand the pathophysiology. And again, to thank Professor Roten, because I bring your attention this very important, maybe not familiar to you, meticulous work on the microsurgical anatomy of the dural arteries. Whoever does meningiomas, dural fistula should read this article. So in conclusion, you know, if you know the pathophysiology, you can make a simple operation and then do the correct indication for the cases. Thank you very much.
Thank you very much. That was perfect as usual, despite the fact that most of them are done by endovascular means now. The surgery is very beautiful. So before I shall hand over to Ekehard Kasper, I would like to ask Aip Cherian. Aip, are you ready to give a lecture?
Yes,
Yeah.
I've been waiting for 2 days. I am more than ready.
I see. All right. Vascular anatomy and important tenets of clipping intracranial aneurysm. Professor Cherian, please.
Thank you, Vlad. So I am sharing my screen. Can you guys see my screen?
Yes, everything's all right. You have your 20 minutes. Go ahead.
Right. So I'm not going into that carotid anatomy of mine. Otherwise, Vlad is going to have a seizure because he's heard it so many times. Now, this is an ACOM aneurysm. I just wanted to show you a few things that if you don't have your 3D imagination, what can go wrong? That's exactly what I wanted to show you. So you're opening. This is a pretty bad bleed. It's done 5 years before. You can see we opened a 3 or 4 centimeter incision, and we are just identifying the carotid here. And since you saw the scan, you probably know that the aneurysm is between the 2 optic nerves. So if I go try and dissect the A1, it's going to be a long, after you saw the scan, you must probably know that the A1 is curved backwards like that. So here I've exposed the aneurysm. You can see the aneurysm starting to get exposed. So here our proximal control is ICA. And I must know where exactly, because I'm exposing the aneurysm first. I'm not exposing anything else first. I'm exposing the aneurysm first. So we don't have, our proximal control is just IC, and very soon you will even see the rupture point. So I'm going to show you even the rupture point on this aneurysm. And you can see that clot there, the blackish clot will be very clear once I take off the arachnoid. So I am right now dissecting the fundus of that aneurysm. Taking the arachnoid off the fundus of the, and you can see the blackish area there, which, sorry for the poor quality of this. It was about 5 years back. So this is the aneurysm rupture point. This is the rupture point. You can clearly see the rupture point there, and that's the neck. That's the neck. And now, this is where you expect this aneurysm to rupture. And so I'm not exposed. I have exposed the rupture point. I have exposed aneurysm. I have not exposed laterally. And now I'm trying to get the neck. Yeah. So you got the optic nerve there. You got the carotid there. A1 is somewhere behind there. So the rupture point is right there. And I'm going to see and get the neck so that I can put the clip on. So here, your 3D anatomy should be very clear. You should know where the ACOM is. You should know where the A1 is. You should know where the A2 is in the hemispheric fissure. This is very important because here the only thing exposed is the aneurysm and the rupture point. And that is when the rupture happened. So it is not from the rupture point before, it's from the neck. So this is a little rather difficult proposition. So here, you can see we put a clip on the IC, and now I know that the rupture point is somewhere near the neck, not where it had ruptured earlier. So I was trying to mobilize that neck from the optic nerve, and that's exactly when it ruptured. So I'm trying to find out where is the rupture point. It was the rupture happened at 14:38. We have about 5 minutes safe. So I've now outlined the entire aneurysm there. That is the aneurysm. You can see the A2 going there, and there is the neck from where it is ruptured. So I am going ahead and I'm going to put the clip on right now. So IC clip really doesn't help you to clip an ACOM. In fact, one A1 clip also doesn't help. You have to put clips on both A1. But see what's happening right now. So it's flooding the field. So I'm taking the patty off. going for a direct suction there, and then I've identified this is the tear in the neck. So I'm going to incorporate that gently, bring my clip up till I incorporated the tear completely, gently, and there is the clip. And now you can see all the vessels, A1, A2, ACOM, and the aneurysm completely clipped. So this is another case where this aneurysm, this PCOM was stuck to the tent. You retract this PCOM, it's going to rupture. It's stuck to the tent and it's riding over the third nerve. So you can see the IC, the PCOM is going there, it's below the tent, that's a tent there. So I have to excise this tent. So I have to first bipolar the tent with very low current because I'm right over the aneurysm. So I'm going to bipolar this tent, and then I'm going to use a 15 blade right over the aneurysm. So in fact, a blade is what is best. So I'm cutting it so that the curved point of the aneurysm is actually beyond. So the curving point is beyond. So I'm close to the aneurysm, but I'm not cutting over it. So now bipolaring and cutting the tent. See how densely it is stuck to this. So slowly I'm able to gently mobilize the tent and remove the tent away from. It's like removing a tumor, and now I'm going to separate it from the third nerve. So you can see that's a third nerve there. Down there, that's a third nerve. And so I'm going to separate it from the third nerve. So the PCOM is going that way. I have separated this aneurysm now. So I want to see what's the shape of this aneurysm. The third nerve is completely free there. Gently, this is with no proximal control right now, no proximal control. So we are slowly taking it away from the third nerve so that the patient's third nerve palsy, partial third nerve palsy improves. And this is a ruptured aneurysm. So that's a bit of a tent stuck to the fundus there. So I'm getting a measure of this aneurysm, and right now through that I know where the PCOM is and I go for the clip there. That is the clip. And that's the end of it. Now, ICG, now that's a paraclinoid aneurysm. In fact, we are going to do one tomorrow. So that is the clinoid process, and you can see that the aneurysm is right there. The aneurysm is right there, okay, underneath this clinoid process. So I'm going to remove this clinoid process extradurally, and you will see how close we are to the aneurysm. And that's what I wanted to show you. So when you're doing next, so you can see the aneurysm there. So you're going to drill the clinoid process right now. After I have done the early transcavernous dissection, so I have opened up the clinoid process right now. Orbitomeningeal band has been cut, and you can see the dissection has been done up to V2. So the clinoid process is right opened up there, and now you have. So we have to we have to drill under complete irrigation. So that's what I'm doing right now, gently. And then now cutting furthermore to open up. This is axial unlocking. I call it axial unlocking. So once you do the axial unlocking, you can furthermore mobilize the clinoid there. And then you can drill it further, thin it out. Here, you obviously cannot pull out the clinoid extradurally because that may be a bit adventurous. So you are thinning down the clinoid to literally eggshelling the clinoid. And you must know that you have the optic nerve there. That's the optic nerve, that part. where my drill is right now. So that's optic nerve roof. It's already been de-roofed. And it's only the clinoid and the optic strut which is remaining. And the aneurysm is right underneath you, right underneath. I'll show you the discoloration of the dura. Now I'm drilling, taking eggshelling it off and removing the clinoid as much. So now we're going further. Now we'll have to use a small drill because the space to the optic strut is not very good. So now you can see the optic nerve very clearly, that this is the optic nerve. That is the optic nerve, and this is the strut. And the aneurysm is just beneath the optic nerve. So when you're going to drill the strut, you are very close to the aneurysm. Now I mobilize this a bit, and you can see that is the optic nerve. This is on the very end, and I'm going to drill the remainder of the clinoid, and you can see the discoloration here. Please see the discoloration here. That is aneurysm. That's underneath the dura. So under very high zoom, we go ahead and drill further and mobilize this, and you can see now the aneurysm very clearly underneath the dura there. That's optic nerve. And now I'm using a 1 millimeter drill to drill the strut off. Very gentle paint-like usage of the drill and you must be very careful here because a 1 millimeter, this is a 1 millimeter drill is literally like a needle. It can pass through, and you shouldn't even think about that possibility because that can kill you here. So here we are completely thinning down. That's the aneurysm there. That is optic nerve there, and you are going ahead and drilling out all the remainder of that clinoid and strut, and that is your aneurysm. So now when you're going to open your dura, things are much more easier for you. Drill out everything, and then after that mobilize. Irrigation at each point. Drilling the rest of the optic strut there. So you can see that's the optic nerve there. And under very high magnification, drilling off all that bone gently. And all the while you can see that the aneurysm is lurking there underneath the dura. Mobilizing. Drilling. Taking out everything now. And you can see the aneurysm there again. There's a large one. You can see the discoloration of the aneurysm there. Removing all that bone clearly. Now opening the dura. And once you open the dura, you just have to cut the falciform ligament. You can see you cut the falciform ligament, and there you have the aneurysm. The clinoid is not there anymore. Clinoid, not the clinoid, not the optic strut, nothing is there. So it's rather not very difficult to cut this falciform and get excellent control of this aneurysm. So you cut the falciform back into this dura, and then you have good control now. So you are going to mobilize that dura this way, cut the proximal ring, the remainder of the distal ring, cut the remainder of the distal ring, And then now you have the aneurysm. So that is the C3 carotid going down. You have to be parallel to the C3 carotid. That's very important because otherwise, if you cross clip, you can clip the carotid off. This is very, very important. So you have to be parallel. So your clip blades are parallel to this. You can see the C3 carotid going down into the cavernous sinus because you cut the rings now and you are going parallel to the C3 carotid. You can see the C3 carotid dipping down there, and you put your clip. And you can see the C3 carotid going down, and that is a clipped aneurysm. So that's the optic nerve, that's a clipped aneurysm. That's a basilar, that's a backward pointing basilar. So we are going to do the same dissection, take out the clinoid, and once after that we can open the optic nerve is there, and the carotid is here, and you're going to see the third nerve there, and so I'm going lateral to, that's the carotid, that's the PCOM. The PCOM leads to the P1 segment, so you know, and the anatomy, that's a third nerve, and now I'm going in between the optic and the carotid at very high zooms, developing a plane between the optic and the carotid. Also doing a proximal sylvian dissection so that I get more space. You must cut all the arachnoid because in this field, because this is what gives you excellent space. You can talk about a lot of different classification, but I don't like classification. Whatever arachnoid is in my way, I take it. So now that's the third nerve. So that's the carotid, the PCOM, very clearly seen. And that's the A1 there, that's the optic nerve. Membrane of Lilliquist is being cut at a very high zoom. And you can see the basilar there. The thing is, now you have to find the contralateral third nerve. That is what helps you to identify which is the P1 and which is the superior cerebellar. So you can see the third nerve there. The white part is the third nerve. So anything above the third nerve is P1. So that is P1, this is P1. And this should be the aneurysm. It's backward pointing, you see, that's the thing. So whenever you have a backward pointing aneurysm, it's not a great thing to do operate on. So this is backward pointing. So you are taking out, you are making a plane between the P1 and that's the aneurysm. So once you get backward and one side pointing to this side. So that's the aneurysm neck. Once you get a good plane on the aneurysm neck, you are ready to go ahead and clip this. So you have P1, you have basilar, contralateral P1, that's the aneurysm. We're going through the opticocarotid window. So we go ahead through the opticocarotid window, and then you go ahead and keep on opening and closing the clip, gently opening, and this will improve. This will increase your space. So your 3D perception in this depth is difficult. You know, your clip perception in this kind of depth through this window is, although the microscope gives excellent 3D view, but at this magnification, your 3D depth is a bit off. So that
2 minutes,
yeah, I'm done, Vlad. It's less than 1 minute for me now. I'm done. So that's a clip. It's the aneurysm is clipped, and that's it. Thank you. Thank you very much.
Thank you, It was great. And I will hand over, since I must leave, to Eckhard Kasper. Ek, are you here? He told me he's going for a meeting. So he's probably not at the back. So let's go. Oh, are you there, Ek? If not, I will ask Victor Hugo Perez to give his lecture on the art of vascular anatomy from the brain to spinal cord. Victor, please.
Thank you so much.
You can call the guys.
Let me share my screen.
Vladimir, before Victor start, I'm around if you need to go for your urgent meeting. Okay.
Yeah, I know. Thank you, Imad. Thank you. Bye-bye.
No, Imad.
Can you see it?
Yes, sir. It's okay. And goodbye,
Okay.
everyone.
Okay, thank you so much. Is in the whole screen? Yes.
Yes.
Okay, thank you. Thank you so much for this kind invitation. I'm going to talk about the art of vascular anatomy from brain to spinal cord. This is in honoring for Dr. Broughton, a giant, a great brain surgeon, and also the great neuroanatomist. In this video, I am doing injection of spinal veins of the cortical.
Victor,
yeah.
we can't observe the video, and your presentation is not in a full screen presentation.
Okay, let me think what's going on. Now it's in full.
Perfect. Yes, go ahead. Thanks.
And can you see the video?
Yes, sir. It's all right.
Yes.
Okay.
Yes.
In the left side, I am doing an injection of the cortical veins of the lateral aspect of brain. I think this can reveal us some important aspects of the vascular anatomy of the veins. And in the right side, I am doing injection of the posterior aspect of this spinal cord. This is also a beautiful videos in order to understand anatomy of the vasculature of a brain and spinal cord. In this video, I am doing an injection of the middle cerebral artery, and here we can see the lateral aspect. And if we inject these brains, we could have some leaks, as you can see in here. But I continue with the injection in order to go to a very, very small arteries, as you can see in this. For example, look at this. Here with the pressure of the injection, it doesn't matter if we have a leak, we can clean the leak, and I continue the injection, and we can see these very small arteries. The supratentorial arteries include the supraclinoid portion of the internal carotid artery, and its anterior and middle, cerebral, ophthalmic, and posterior communicating segments, and anterior choroidal branches. The components of the circle of Willis, which in the posterior midline includes the basilar apex, and finally the posterior cerebral artery. The origin of all of these arteries is located deep under the center of the cerebrum, and their proximal trunks are relatively inaccessible because they course in deep clefts like the sylvian or interhemispheric fissure. The segments of the internal carotid artery, this is divided into 4 parts: C1 or cervical portion, C2 or petrous portion, as you can see in here, C3 or cavernous portion, and C4 supraclinoid carotid. The C4 begins where the artery emerges from the dura mater, forming the roof of the cavernous sinus. It enters the cranial cavity by passing along the medial side of the anterior clinoid process and below the optic nerves. It courses posterior, superior, and slightly lateral side of the optic chiasm and bifurcates below the anterior perforated substance at the medial end of the sylvian fissure to give rise to the anterior cerebral artery and middle cerebral artery. Posterior communicating artery. The PCOM-A forms the lateral boundary of the circle of Willis, arises from the posteromedial surface of C4, approximately midway between the origin of the ophthalmic artery and the terminal bifurcations. It joins the posterior cerebral artery. Here we have an hypoplastic posterior communicating artery. It measures less than 1 millimeter, and it was coined this term by Dr. Albert Roton. Here, this is a close view to look these beautiful arteries. The anterior choroidal artery reported clinical features of occlusion of this artery are contralateral hemiplegia, hemianesthesia, and hemianopsia. The contralateral hemiplegia and hemianesthesia results from infarction in the posterior two tiers of the posterior limb of the internal capsule and the middle tier of the cerebral peduncle. Here we can see the optic nerves, the anterior choroidal artery. This is really nice artery, anterior choroidal artery and lenticulostriates arteries. The anterior cerebral artery is the smaller of two terminal branches of the internal carotid artery. Arises at the medial end of the Sylvian fissure, lateral to the optic chiasma, and below the anterior perforated substance. It courses anteromedially above the optic nerve or chiasm and below the medial olfactory striate to enter the interhemispheric fissure, the anterior cerebral artery. The anterior cerebral artery is the smaller of two terminal branches. The internal carotid artery arises at the medial end of the Sylvian fissure, lateral to the optic chiasma, and below the anterior perforated substance. It courses anteromedially above the optic nerve or chiasm and below the medial olfactory striate to enter the interhemispheric fissure. Anterior communicating artery. The microvascular anatomy of the anterior communicating artery shows great variability in its shape, diameter, and length, presenting fenestrations, duplications, and triplication. Here we have the A1 segment and the anterior communicating artery. The A1 is the favorite site on the circle of Willis for hypoplasia. A1 hypoplasia has a high rate of association with aneurysm. It is found with 85% of ACOM aneurysm. It is the only anatomic variant that correlates with the location of cerebral aneurysm. Roton used to say this important concept. Here we have the branches that are coming directly from anterior communicating artery. Hypoplastic, short and long anterior communicating arteries are also observed, as well as the presence of communication between both anterior cerebral arteries due to the union of the respective walls, but without the formation of a true anterior communicating artery, as you can see in here. Both anterior cerebral arteries are joined, and we cannot distinguish a real anterior communicating artery. The recurrent artery or Hübner artery. This branch is the largest, arising from the A1 or the proximal 0.5 millimeters of A2 in the majority of hemispheres. It may infrequently be absent on one side or arise as several branches. Here we have the Hübner or recurrent artery. The circle of Willis is formed by anterior communicating anterior cerebral arteries posterior communicating arteries and posterior cerebral arteries. Here I am doing a dissection in order to find the anterior part of the circle of Willis. And here we have a good anterior communicating arteries, anterior communicating artery, as you can see in there. And here we have the recurrent artery or Hübner artery. Anterior A1. This is the right Hübner artery and the left recurrent artery. The middle cerebral artery arises as the larger of the two terminal branches of the internal carotid artery. Diameter is about 4 millimeters. Here we have a dissection of this middle cerebral artery in order to see the M1 segment and the lenticulostriates arteries. M3 segment begins at the circular sulcus of the insula and ends at the surface of the sylvian fissure. I dissect here the temporal and frontoparietal operculum in order to find this important artery. The posterior part of circle of Willis is the most difficult sites to approach surgically. Here we have this posterior, the posterior part of circle of Willis, and I am showing you these branches of the tip of the basilar artery and P1 segment of PCA. And this is another beautiful picture to show the lateral aspect of the brain stem, an absence of the posterior communicating artery. This is very unusual to find this fissure. The cerebellar arteries is like the magic number, as Dr. Roton said. Let's go to see some aspects of the vasculature of the spinal cord. It was Albert Adamkiewicz who discovered the important artery that irrigates the spinal cord. So here we have an injection of this vein, and we can find several morphologic variations of this vein. Here we have also a dissection once we have injected this spinal cord, and here I am doing a dissection of arachnoid membrane in order to see these spinal nerves. The spinal cords were extracted via a longitudinal midline posterior incision from the occiput to the sacrum, from C1 to L5, the right side. Then after they were injected, and we find the great anterior radiculomedullary artery, Adamkiewicz artery, that looks like a hairpin. This is an injection of this Adamkiewicz artery in this spinal cord. We can move the cursor of this video in order to show this injection of this artery. Although variability exists to the overall caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. This, for example, the highest level of the Adamkiewicz artery was found at T3, as you can see here. Here we have the 8 cervical spinal nerves, and 1, 2, 3 thoracic nerves. Here we have the origin of this Adamkiewicz artery. And this was the lowest level coming from left to this artery. The great posterior radiculomedullary was also a topic for understanding vascular anatomy. For example, this is very important. Various authors postulate such a vessel like this, but others do not mention it or even deny its existence. And we found this artery, and there is no doubt about its existence. This is the great posterior radiculomedullary artery. This is a small video to show
posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves.
This was published in the American Journal of Neuroradiology, and this is very, very beautiful to study these arteries. Another technique to study anatomy is the Mulligan technique. Here we have a cut without the staining, and maybe it's difficult to find some tracks, but if we do this kind of staining, we can see very beautiful aspects of the anatomy. This is another axial cut to show these structures. For example, in this, this is really beautiful. This technique shows and we can define the gray substance with the white tracts. So look, for example, in this, and for example, in this, we have a sagittal cut to show this, and in here we have the genu of internal capsule, pulvinar, stratum zonal of thalamus, but if we don't do this Mulligan technique, it's a little bit more difficult to find these anatomical structures. So in here, for example, the genu of internal capsule, the anterior limb, the head of caudate nucleus, stratum zonale of thalamus, dentate nucleus, and middle cerebellar peduncle. This is really enjoyable and beautiful to study in this kind of stained cuts of brain. This is another aspect that I have developed for several years, is to make some models made of resin, like this is, at the moment, this is like a toy for me, but this is really beautiful. The spinal cord in here was doing in phosphorescent color. So we are going to have the National Congress and First Intercontinental Congress. We hope, because the prognosis for decreasing of COVID is going to be good. at November this year. Hope you could come. And this is real good for all the Mexican people. Today is a national holiday here in Mexico, the Independence Day. So thank you so much for this great opportunity to Dr. Vladimir, to Dr. Ahmad, and all of you. Thank you so much.
Thank you, Victor, for this very elegant presentation on the vascular anatomy. We move to the next speaker. I'd like to invite Professor Basil Ganglia from Turkey. He is invited faculty, and he's going to talk about the supracerebellar transtentorial approach anatomy for the posterior cerebral artery aneurysm. Professor Ganglia, are you with us? I see your slide.
Yes.
Okay, you can go ahead, please.
Okay, thanks for the kind invitation. It is an honor to be part of this meeting. Today, I will talk about the supracerebellar transtentorial approach to PC aneurysm. I have no conflict of interest, and the photograph taken from our articles and Roton collections. And I will show one of my cases done with this approach to the P2 aneurysm. Firstly, Dr. has mentioned about the anatomy of the arteries. We are looking from the inferior, and you can see the P1, P2 in the crural stand, and the P3 in the ambient stand, and the P3 segments of the posterior cerebral artery. And we are looking from the lateral through the choroidal fissure. You can see the P1, P2, and P3 segments. And even though Oliveira describes the approach to the posterior cerebral artery aneurysm, and as you see, the posterior part of P2A and P2P and the P2 arteries are usable to approach with this supracerebellar transtentorial approach. And there are some approaches described for this segment, for example, subtemporal approach. But in this approach, you need to attract the temporal lobe, and also transtemporal, transchoroidal approach you can use to approach P2 aneurysms, but you can damage these tracts. And I will talk about the supracerebellar transtentorial approach. And as you see, it has modification as median, paramedian, lateral, and extreme lateral supracerebellar approach. And we are looking at the posterior. We remove the tentorium. You can see the cerebellum and the inferior part of the occipital and temporal lobes. And you can see pineal gland and tentorium. We can show via supracerebellar approach pineal gland, superior colliculus, inferior colliculus, trochlear nerve, and sometimes vermis can obstacle you for approaching the inferior collicular and trochlear nerve, and you can use a lateral approach. And we go beyond. You can see the thalamus and the posterior cerebral arteries. You can see here posterior cerebral artery, and we are looking from the superior. As you see, from posterior cerebral artery is located superior to the tentorium. Because of this, if you want to reach P2 and segment, you must open the tentorium. I will talk about the supracerebellar approach. The most important structures is the transverse sinus and confluence sinum in this approach. Then the one of the most important things via this approach is the bridging veins. You should preserve these veins. Also, it can be deeper or cervical. You can see more bridging veins in the deep of the supracerebellar surface. And we are looking from the superior. You can see their drainage. And after going beyond, you can see pineal gland and the quadrigeminal cistern and also corpus callosum and vermian vein. And if you go more anterior, you can see the posterior cerebral artery. And after opening the tentorium, you can see hippocampal gyrus and the P2 and P3 segments. As you see, it is easier to proximal contour because it is located more below the P3 segments. Also, we did some study about this approach via robotic systems, and I have a video to show this approach for P2 aneurysm. This is, I used semi-sting position because you know we have some problems about the anesthesiology with sting position. And you can see the MRI of the patients. In ambient cistern. The aneurysm located superior to tentorium in the ambient cistern. And you can see the angiography. This is a P2 aneurysm. And I use lateral semi-sting position for this approach. And I used a craniotomy seeing the transverse sinus. Before opening the dura, I always opening the cisterna magna. Relieve the vein and drainage the CSF. Then I used almost linear incision to the transverse sinus. Sorry about that. After opening the door, you must cut the tentorial attachments. And you can see the bridging veins located supracerebellar surface. And you can preserve by dissecting them. And after dissecting, you can you can open the quadrigeminal cistern. And also you can see the posterior cerebral artery just under the tentorium. And in this case, we had the injury in dorsal branch of the P2, and we used a clip with preserving the flow of the artery. And you will see the angiography, it still works. And then, sorry. After cutting the tentorium, we will see the fourth nerve, and they attach it to our approach. And we can reach the aneurysm. And firstly, you can use the proximal P2. And after proximal control, you can dissect the aneurysm. And you can puncture if it is a big. Then put your clips. And you can control the flow of the distal to aneurysm. And also you can coagulate the aneurysm. This is the before the operation. After the operation. You can do without retraction in this position. Without any deficits. And you can see the postoperative angiography. And also, I will show a video about our laboratory in Yeditepe University, Istanbul. You can come this laboratory and have projects. Thank you very much.
Thank you. Professor Abuzur, for being on time and showing this video. We'll move for the next speaker, and last but not least, Professor Matthias Baldoncini from Argentina is going to talk on the anatomy and surgical consideration of petrosal veins, a very important subject. Matthias?
Yes.
If you can share your, very good. We see your presentation. Go ahead.
Good morning, good afternoon, good night to everyone. Thank you again, Professor Ayman Kanan, for the invitation. It's a huge pleasure to me and for each neuroanatomist around the world to be present in this important webinar honoring the lifetime achievement of Professor Albert Roton, who gave us to every neurosurgeon and the importance to have in mind the microsurgical neuroanatomy with so special detailed descriptions and the impact in our surgeries has been and is very, very important. Thanks again. I want to share with you a topic about a venous structure that it's not so frequent to talk about it. And this topic is related with to the veins that drains to the superior petrosal sinus. When we have to reach in our surgeries to the trigeminal nerve in order to decompress the trigeminal nerve, or in order to resect small trigeminal schwannomas or meningiomas to these portion, frequently, very frequently, we find in our surgical corridor with bridging vein that connect the cerebellum surface or the brainstem surface, anterolateral surface, to the superior petrosal sinus. And sometimes when we find this vein, frequently we think that it is proper to coagulate and cut it or not. And we want to share our experience and our own classification of these bridged veins in order to our experience. First of all, we need to remember that the anterolateral surface of the brainstem and the petrosal surface of the cerebellum have many venous structures. Some of these are small veins that connect the pial surface of the midbrain, the pons, and the upper surface of the medulla, and the petrosal surface of the cerebellum. Professor Roton in his book described each vein in a detailed way. We have the proper name of each veins, but it is very important to remember that these veins from the anterolateral aspect of the brainstem and from the petrosal surface of the cerebellum usually drains as bridging veins to the superior petrosal sinus. But it's important to remind that the most medial bridging vein that drains to the superior petrosal sinus frequently are the veins that drain the venous blood of the brainstem, and the most lateral one are related to the drainage of the cerebellum surface. There is an important article that the name is Anatomy of the Superior Petrosal Veins Under Exposure and Management During Petrosal Apex Meningioma Surgery, but it is important because these authors divide in 4 groups the veins that drains in the anterolateral aspect of the brainstem and cerebellum. In 4 groups: the anterior pontomesencephalic group, the petros group, the tentorial group of the veins, and the posterior mesencephalic venous group. I strongly recommend the reading of this article because it's interesting in order to comprehend the venous drainage of this aspect. Here we have an anterolateral view of the brainstem and cerebellum, and again, we can classify in anterior pontomesencephalic group, the petros group, tentorial group, a pontomesencephalic group. And frequently, these 4 groups, from medial to lateral, drains as a common bridging vein to the superior petrosal sinus. Here we have an interesting 3D modeling of the venous sinus of the skull in general, but we need to put attention in this sinus, in the superior petrosal sinus, especially focused when we need to access to the pontocerebellum angle in retrosigmoid approach for different kinds of pathologies, because this bridging vein we can find during our microsurgical trajectory. Of course, when we think to approach lesions or neurosurgical real scenarios through the retrosigmoid approach, we need to think in neurovascular decompression, not only to the trigeminal nerve, because sometimes we need to decompress the fascial nerve or the lower cranial nerves, schwannomas of the trigeminal or of the vestibular schwannomas, meningiomas, and epidermoid tumors located in the cerebellopontine angle. In a higher view of this beautiful specimen, we can observe the 7 and 8 cranial nerve, the 5 cranial nerve, and here we have an important structure that is an interesting landmark, like a GPS in in our retrosigmoid approach, that is the suprameatal tubercle, because it is located above to the internal acoustic meatus. This landmark is really, really important for us because we use it to classify the bridging veins that drain to the superior petrosal sinus in 3 subtypes: medial to the suprameatal tubercle, located over the suprameatal tubercle, and lateral to the suprameatal tubercle. Here we can observe an anterolateral, and posterolateral view of the tentorial surface of the cerebellum, and here we are observing a bridging vein that drains the lateral surface of the brainstem, the lateral surface of the pons, and here is receiving vein to the tentorial surface. And it is located medially to the suprameatal tubercle. Here, another beautiful specimen where we can observe a vein, a bridging vein that drains over the suprameatal tubercle that was drilled here. And it is located at the level of the suprameatal tubercle. Here we have another vein that it is medially to the suprameatal tubercle. It's very important because we need to take care, especially with the veins that are located medially to the suprameatal tubercle. If we perform in this cadaver a retrosigmoid approach, a classic retrosigmoid approach, where we can observe the tubing line that is an important landmark for the posterior fossa, but we think that, agreeing with several authors, that the suprameatal tubercle is another important landmark, like anatomical GPEs, in order to localize the different structures located in the cerebellopontine angle. Here we have a vein that drains over the suprameatal tubercle, and we can find veins located more medially or more lateral. And these are original drawings that will be part of, hopefully, of a paper that we are preparing to send for the analysis for publication, where we divided the veins in retromeatal bridging veins, meatal bridging veins located at the level of the suprameatal bridging vein, located medially, and most of time located at the level of the trigeminal nerve. And some of these veins could be related with the venous compression of the trigeminal nerve. Here we have a beautiful dissection in a superior view, where we have two kinds of vein. We have here a retromeatal vein here, and a premeatal vein, two premeatal veins in medially located. Retromeatal vein, and here we have two veins located in close relation with the trigeminal nerve, sometimes related with trigeminal neuralgia, when the trigeminal nerve have not arterial conflicts. The vein could be related with pain. And it is important not only for operate neurovascular trigeminal neuralgia due to vascular compression, and here we have another, this is a fascial compression with the ICA, and here we can observe in the same patient a tumor located in the trigeminal porus. This is a trigeminal schwannoma with a vascular compression. The patient suffered fascial pain, and the patient suffered tinnitus and vertigo too. Here we have several cases of different tumors located related with the cerebellopontine angle. These are all different kind of schwannomas. And here we want to present different surgical scenarios, especially applied to trigeminal neurovascular decompression of the trigeminal nerve. Here we have the suprameatal tubercle, and this is a perfect case of a retromeatal vein, bridging vein. And it is impossible to reach the trigeminal nerve without coagulating this vein and cutting the vein, as we can observe here. And here we reached the trigeminal nerve, where we can observe that the ICA crossing under the trigeminal nerve, and here it's the artery and the vein decompressed using a small piece of Helfo-Alm or Teflon. Another case of a retromeatal vein, here is the suprameatal tubercle, and this vein was coagulated and cut, as we can observe here. Here is the suprameatal tubercle. That is an important landmark to choose if I am able to coagulate the vein or not. And here the trigeminal nerve decompressed. Here is a case of a meatal bridging petrosal vein. Here is a simple, a unique vein draining to the superior petrosal sinus. Especially for young neurosurgeons or for residents, there are a way to know where the superior petrosal sinus is located. If we follow the dura mater that covers the suprameatal tubercle, there is a point or an angle where the dura mater turns, and the direction is from anterior to posteriorly, that is the tentorium, and in this point, in contact with this two layers of dura mater, is located the superior petrosal sinus. This vein should be coagulated in order to reach the trigeminal nerve, again for another trigeminal neuralgia due to an arterial compression of the nerve. Another case, here we can observe a small suprameatal tubercle. In each case, we observe the suprameatal tubercle. Sometimes the suprameatal tubercle is small, like in this case. Yes, we can observe a small suprameatal tubercle, and sometimes it's really huge. And especially if we need to reach medial surgical goals like a compression or a tumor, sometimes the suprameatal tubercle is in the middle of our surgical corridor and needs to be drilled out. Here we can observe two meatal veins that were coagulated in order to decompress the nerve to this dolichothoracic vertebral artery compressing the nerve. In this case, we can observe a postmeatal bridging vein. Here is the suprameatal tubercle, and medially to it, we are observing this suprameatal, these two postmeatal veins. Here, the veins were divided, and we work between the angle of these two veins until the end of the surgery. Another case of a postmeatal vein, here two postmeatal vein. In this case, we need to cut the superior one in order to reach the trigeminal nerve and decompress the nerve to the arterial compression. Here is a beautiful dissection where we are observing a postmeatal vein here, and with the endoscope we can observe that the postmeatal vein drains some of the veins of the pons and the middle cerebellar peduncle. Not only for neurovascular decompression, it's important to keep in mind the importance to preserve the veins or coagulated. If we are operating tumors located on the posterior fossa, like in this left retrosigmoid approach for a schwannoma. This is a case of a small schwannoma, and here we have the suprameatal tubercle, and this is a postmeatal vein, and we know that this vein is important to preserve to the end of the surgery, because some of the veins that drain through this postmeatal vein, bridging vein, are the veins that drain the lateral surface of the midbrain, the lateral surface of the pons, and the venous infarction of this more medial bridging vein could have to the patient some kind of morbidities after the surgery. We are removing the tumor, and this is the final view of the surgery with this postmeatal, premeatal, bridging vein medially located to the suprameatal tubercle. This is another case of a huge schwannoma, Hanover 4B, a solid tumor. This is the intracanalicular part that is removed following the tubing lines. And here we can observe a medial bridging vein draining to the superior petrosal sinus that need to be preserved. In order to summarize, all veins located medial to the suprameatal tubercle in our case of several surgeries were preserved in order to avoid venous infarction. The veins located at the level of the suprameatal tubercles and lateral to the suprameatal tubercle could be coagulated because the patient have not any problem in the postoperative period due to this vein drains the petrosal surface of the cerebellum. And finally, in order to finalize this lecture, I will have here an interesting words from Professor Albert Roton. If we keep doing more, we will find more. Each advance redefines what we do for our patients. Thank you very much again for the invitation, Professor Ayman.
Thank you very much, Matthias, first for bringing this subject again that we have an expedited discussion about yesterday, the importance of the venous system, and you illustrated very nicely with your presentation. And I think Vinko will stress this point that he mentioned it yesterday. Don't take veins easy, because wait and see, you will get your complication if you are paying no attention to this vein. Vinko, you'd like to give a comment on this? Unmute yourself, Vinko. Unmute. Unmute. Next to the video sign, there is a mute and unmute.
Imagine. Why Vinko is trying to open?
Yeah, I'm coming to you because I have a question for you. I know you have the highest expertise in the vascular decompression among the presentee and internationally, and I'd like to hear your comment. Please go ahead while we are waiting for Vinko.
No, well, I have two comments about the vein. You have a wonderful lecture about the
okay, I'm with you now.
Okay, Vinko, go ahead. I will talk.
I'm sorry. You know, the whole afternoon, I can only say that how privileged we were to be able to go through the beautiful neuroanatomical galleries. And I'm so happy I did not hear a word about neuronavigation. I'm so happy that neuroanatomy is our neuronavigation. And arteries are so variable, as it was shown by authors, and the veins are even more. And I think that it is much easier to describe than to define the arteries and veins. And that's why this is a guarantee that neurosurgeons will always have to go to the lab. Maybe even more frequently than to the operating theater. But I would just mention two things to Thomas Santorio's lecture. I did not hear about the hypothalamic tumors, which can be nicely reached through interhemispheric, transcallosal, and there is a trick I found, that you have to find the thalamostriate vein and go anteriorly to it and then medially. And maybe just one suggestion: do not use coagulation, because when you are in the caudate nucleus, you are very close to the internal capsule. And it was nicely stressed by the vascularization from the anterior cerebral artery, how it contributes there. And the last, what I would like to mention are the tumors in the lateral ventricle at the posterior medial side of the trigone. And then you may have a bad result if you don't know where the structures are medially on the other side of the ventricles. This is all what I have to say.
Thank you. Very valuable information. Giovanni.
Yes. First, about the vein problems. I think for the young people, if you close an artery, you have immediately the deficit. If you close a vein, wait 24 hours and the deficit will be worse than what you are expecting. I completely agree with the approach for the decompression. In another seminar, another webinar, I propose to see if you can, in very difficult case, close the vein during the angle, pontocerebellar angle, to have a temporary clip and use the ICG that is giving you the idea if the drainage is still present or not. That is a little bit technical advance, and I know that in many places ICG is not yet used routinely, but the microscope, all the brand of microscope now, they have this possibility. For the lecture of Santorio about the lateral approach, Vinko already said about the hypothalamic tumors. I think that in this case, one has to be aware that also the endoscopic approach may be useful, transventricular endoscopic approach. But what about, I didn't heard that he was giving quotation to the Spätzle contralateral approach for the ventricle. Do you have any comment about that? That was my comments.
Yeah, thank you very much, both Professor Dolic and Professor Broggi, for your comments. Fortunately, I kind of ran out of time to go through all the other approaches. Plus,
I cut your time. That's my fault.
I try to sort of limit to talk to lateral ventricles rather than hypothalamus, although, as you could see, some tumors inevitably take you down from lateral ventricle to the hypothalamus anyway, particularly in the sort of around the frontal horn area. So definitely, I mean, the contralateral approaches are used very frequently, and each approach is very much tailored to exactly where the tumor is, where it extends, and so on. So it's probably best taken case by case, and it's kind of 3-hour at least discussion to cover it. But it's very important to have all these approaches in one's armamentarium, because not every tumor in the lateral ventricle is best approached interhemispheric transcallosal for sure. And the approach can be ipsilateral, contralateral, and so on. So there are numerous approaches, and useful it's important to select the perfect one for the perfect lesion.
Thank you. I have one comment for Darling, Vinko, and Borgi about yesterday. Vinko, you mentioned about Dr. Mallis when he used to propose to put the clip or close temporarily the vein and see the reaction. And this is contradict what we are saying. The effect is not always acute. So you, like in other situation, when we coagulate it and cut it, the effect, as you, Giovanni mentioned, the effect won't be immediate. It might wait and see, and you get the complication 2 days or 1 day later after the surgery. And this is not without risk. If you don't have the option, except to potentially sacrifice, you do this. But if you have the option to save it, for the young generation, always try to save. And the issue of fluoroscopy, the fluorescein, the same applied. You might, if you put the clip and you won't see the flow, but it might not show you the clinical effect on the patient.
Yeah, but at least you know that the drainage, there is no more drainage. I mean, it's more negative than positive.
Oh, this is for the decompression you are talking about, and we are talking about the venous drainage.
Maybe, Iman, maybe I was not clear enough. He put the clips on the transverse sinus because to be sure that the flow can go to the other side, because you know always one is larger than the other one.
Yeah. You mentioned that yesterday. That's correct. Now I want to first congratulate all the colleagues that spoke about the vascular anatomy. There were 3 presentations from Igor, was a fantastic, and from Victor, and there was one from Fernando. This is, I don't think there is any question about them. This is pure anatomy, but they were very detailed and very helpful for the new generation not to miss this part of anatomy and say this is not our part as a neurosurgeon, this is for intervention.
If I may, Iman, as a comment, it kind of ties up very well with what was described about the perforators by Igor from MCA, the thalamoperforators, and actually what Professor Dolan pointed out, that the direction of the thalamoperforators is not straight up, but it's very much lateral to medial, anterior to posterior, and so on. And some of them are short, some are very long. So when the tumor occurs in the thalamus or caudate and so on, one has to be, but particularly in the anterior aspect of the caudate, one has to be very cautious about the surroundings of the tumor and also what type of the tumor it is. In some gliomas, the thalamoperforators can be actually running through it. Even if it's metastasis, the perforators can be right on the capsule or on the surface of the tumor. So both mechanically and certainly thermally, one has to be very much aware of their existence and course.
That's very right. That's very correct. And I think it's no use to say that the approach, for instance, transcallosal, should be in between both of anterior. But people sometimes think, okay, maybe I can go through laterally. No way. You have to go in between.
And that's where anatomy very much comes to existence. Sometimes the arteries from left and right can be
Yeah.
The left can go to right, the left go to right. As Fernando also showed, that there can be tremendous variations in various branches. But actually one needs to take time and identify what belongs to left, what belongs to right. It's similarly with opening and Sylvian fissure, with opening the Tilo-Vila approach and so on. One has to be very clear and meticulous, because when you bring what belongs to the left and what belongs to the right, and what belongs to temporal, what belongs to frontal, in the end, not only it looks nice and you save yourself time on coagulating anything, but also it's safe.
That's correct.
Thank you. I think I'd like to open the discussion on that case from Professor Basil Ganglia about the supracerebellar transtentorial approach, the limitation and the exposure. Of course, he showed a nice video on this one. And we have Bingo, he is the master of aneurysm surgery. What is your take about this approach?
You know, actually, you can reach quite nicely along the ambient cistern laterally. And I was much criticized by operating the pineal cysts when they were large, you know. I have my own explanation for this, why to operate. But here we enter another discussion. But I saw that you can go very nicely laterally, and you can find the malformation there. I had limited experience. I have operated a trochlear nerve tumor, which was it was said that nothing can be done, and it is malignant tumor because it was in the like in the brainstem, you know, but exophytic. It was trochlear nerve, very lateral. So you can reach incisternal ambience by this approach nicely. Operating in the cisternal ambience, I never had the problems with the attachments of the cerebellum to the tentorium. Sometimes you may take more time to go around the Vermian veins, but I think it's a nice approach. Now,
yeah,
if you can use it very far is the other question. Maybe it's better to follow the PP2 from front, you know. So, but it's an option.
Yeah, we have tried this approach in pineal region lesions.
Yeah.
I found it very helpful,
Yes.
but there is a limitation of the lateral exposure.
That's correct.
Yeah, the lateral exposure will be limited.
But
this is why you have to judge it about the location of that vascular, especially if you want to have a control or proximal control on these arteries.
Yeah, but may I mention something else? In some cases, we had minor problems with the veins from the toward the transverse sinus, and we were dissecting, you know, the veins, because we went over the tentorium, you know, and then occipital veins sometimes are more medially, but you can dissect those veins about 1.5 to 2 centimeters, and then you can get more space. Yeah.
This is exactly what we do as well in the parasagittal meningiomas as well.
Yeah.
To dissect the vein to give more space.
Yeah.
I see Professor Atul with us, and keep quiet, and we want to have his comment on this posterior fossa approaches. Unmute yourself. Yes. Atul, good to see you.
So, thank you, and I'm really enjoying the presentations. One question I want to ask at least the panelists. and of course, Vinco. You see,
Yeah.
we talk about taking the Dandy's vein, we talk about the problems related to thalamostriate vein, we talk about problems related to internal cerebral vein, we talk about problems related to vein of Labbé, we know all that.
Yeah.
Now, cavernous sinus is the biggest venous complex in the whole body. It is bigger than superior sagittal sinus. I want to ask you, and I want to ask Vinco and of course all the other panelists, you know, when we operate on cavernous sinus and we pack the cavernous sinus and we pack it with Surgicel and pack it so that there is no venous bleeding, have you ever seen any problem related? You see, it drains the whole eyeball, it drains a lot of brain. Is there any, have you seen, and why? If you have not seen, why?
Very good question. We were operating patients on the steady films, on the steady pictures we got from neuroradiology. So we see what is the situation with arterial and venous system. But when the cavernous sinus is filled with the tumor, it was not filled from today to tomorrow. It was through the longer time. So
over years.
So the drainage found the other ways. I can tell you another very tragic event I had. I operated a patient, removed the tumor completely. It was many years ago. I was somehow absent-minded at the end of surgery and did not put enough material. Now we put fibrin glue. At that time we were putting Surgicel into the empty cavernous sinus. The patient wanted to go home on the 7th day from the hospital. She went to the toilet, she was straining, and she had a bleeding, and she died. So when you empty the sinus, you have to be sure that that the connections might be open to the cross circulation. You have to fill the empty sinus.
There is a nice paper published by Professor Ohata on the reversal of the venous flow.
Yeah.
And this is very important between the sphenoparietal system that we always neglected and the posterior venous circulation.
Exactly.
I have one more comment. Perhaps we've discussed the paper from Professor Rames Quirolo. I thank him for bringing this subject about the fistulas. You made the surgery looks very nice and easy, just putting a clip on the fistula, but you illustrated nice radiological picture how serious this one and how can be affecting any area of the skull base. Any comment on this paper? Or Rames, you want to say something about this paper?
I selected the talk because this is an example where the more anatomy you know, you can make your operation easy and not the other way around. So knowing the anatomy, but some of it I did not go through because I cannot demonstrate to you the hypoglossal branch of the ascending pharyngeal and so on. But this, just to give you the idea how to target your lesion, and if you target, it avoid you doing multiple maneuvers, just to go straight to the procedure and do it. And the simplicity always prevails. So the question comes, say, the examples I gave, because for them, the endovascular require multiple attempts to do it, and usually they fail once and twice. So if you come with a simpler approach, then this will prevail. It doesn't matter endovascular surgery. The simplicity will always prevail. That's why I was choosing this particular.
I like your subtitle, and this is the trick. the eyes do not see what the brain doesn't know.
Yes.
That's the answer.
Yeah,
That's true.
because
Yeah.
the other problem, if you don't have an angiogram and you go in an acute stage and you think it's you're dealing with an AVM rather than a dural fistula, then it's absolutely the opposite maneuvers what you are dealing with. Yeah.
Yeah.
Actually, if I may, on the topic, of course, your purpose, Ramas, was to describe the surgical dealing with it, but maybe some in the audience would want to know, just in two sentences, the principle of endovascular treatment, which is maybe not what everybody would expect.
Well, the pathophysiology is venous hypertension, so you need to disconnect the veins as close to the fistula as possible from the backflow of venous hypertension. So whether you use the transarterial route endovascular is your onyx, because it has to go through the fistula and occlude the vein, not the other way around. Or you can use the transvenous approach.
Yeah, may comment on this? Yeah, completely agree. If you don't treat the vein, your fistula is not treated. And what is very tricky in endovascular approaches, if it's not completely treated, if it's that the interval between procedures is large, when you put your patient back to the ward, you have a lot of recruitment of the vessels that just appear, and you didn't see in the first one, but they just recruited because the vein is not treated and is aspirating, and then the vessels keep appearing. So it was said that, I found it very nice, I don't remember, I'm sorry who said that we didn't mention neuronavigation at all in this session. That's true, it was really nice. But there is something that is coming back, I found it very nice, even it was not said that way, is completely in line with what you're discussing, is the importance of individual anatomy, right? So in fistula is the same, there was so much information on DSA. And before treating a fistula, we can spend hours just looking and trying to understand where are the, how the drainaging is being done, what is coming, what may happen if I occlude here and there. And of course, this also applies for many other topics we discussed this today. We talked a lot about variants and the anatomy, what's not always the same, and all that is in the individual anatomy, surgical planning by anatomy, but by individual anatomy. It means spending time looking at the examination, and planning. So this is navigation, but this is not neuronavigation with technological neuronavigation without brains.
This is brain navigation.
Or dynamic anatomy.
Dynamic anatomy.
Yes.
One more thing about the presentation, the very elegant presentation of Professor Toshio Matsushima on the telovela. I think one of the best presentation on that subject I've seen. Are you with us, Professor Toshio? I think Tokyo or Japan is too late. I see Professor Takashi Kon, who is
now
translating this subject 1 a.m. in Japan, and you can see his eyes keep getting smaller and smaller. Anyhow, it was a marvelous presentation from Professor Toshio. We enjoyed it, and it's a great work that he was a scholar of Professor Wharton himself, so he propagated many of his method and ideas in form of application. I think most of these papers, I think we discussed most of them, unless somebody wants to have additional comment from the panelists. Ramesh, you haven't spoke today, you kept quiet.
Was juggling too many things at the same time, but all the presentations were quite high quality, especially the vascular anatomy. The only thing I want to mention about the P2 aneurysms, some of the P2 aneurysms I have seen in interlocations were dissecting aneurysm, and they have a tendency to get smaller with the monitoring. So your case may be a saccular aneurysm, but the cases I've seen, some of them were a dissecting aneurysm, which didn't require any surgical intervention, and they tend to get smaller with time.
All right, so if no other comment or question, I again thank you. I'm very happy, darling, Vinko, that you were with us on 2 consecutive days full. Yeah, and we hope we'll see you in person and see all of you soon in person. Hopefully we'll find a course that we will do it together, all together. We will invite you, Vinko, and others, faculty, to make one on site and exchange not only talks, but some social conversation. Thank you very much and have a good night.
Thank you.
Thank you. Thank you. Bye-bye.
Let's go to take a picture before you leave. Who is the one who taking the picture? Pablo, are you with us?
Yep, Pablo is
Yes,
there.
I am, but I cannot take picture.
Picture taking.
Picture, and Fernando, drive safely. Are you driving Lamborghini or I see a four-wheel drive?
No, my car is not a Lamborghini, but it's not so bad. It's an Audi.
Okay.
I like very much.
Thank you. Thanks, everybody.
Okay.
Thank you very much.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Thank
Bye.
you.
Thank you. Good night.
Good night.
Night.